في صوت or أنا بكون روح كل كل السلايد. Okay, it's useless. ما في صوت. طيب, in brief, I will tell you. This is a real quality. إحدى سيمفونيات بيتهوفن. There's coordination, there's leadership, there is harmony. They are following standards. They are doing real quality. While indeed, in the next one, there's no harmony. There's more than one leader. People that don't know what to do. There's clear distraction from here and there. And this is the way how we are practicing quality. Even we know everything about quality. So, but without sound, I think it's useless. طيب. Again, without sound, I think you destroy half of my lecture. المشكلة اعتمدت على الفيديوهات كتير. And what he will say, first, do no harm. This is the safety. السلامة أولاً. And I think it's well known. Without sound, I think مشكلة. The best translation I found it for, to err is a human, كل بني آدم خطاء. This one, 1999, Institute of Medicine, they said that we are a human being, and we are doing mistake. And even it looks very simple, but it's changed the whole story of quality. Because the way how we think, the way how to treat the quality, it's totally different. So to err is a human, Institute of Medicine, 1999, they said that the quality is freedom of accidental injury. This is our perception as a physician, as medical staff. We believe that if there's no harm to the baby, that this is a quality. But not all the people will look at the same, from the same angle. So there is difference between how we are looking at the safety from our side and how the family is looking at the safety. So for us, we are focusing if no medication error, no problem, no any accident happened to the baby. Well, the family will focus about something totally different. How to solve this problem, how to make it together. I think we'll have lecture tomorrow, which will be presented about family-centered care. So you can join both together in one view. This is what we call it, family-centered care, and I think it's one of the core important standard of Canadian accreditation nowadays. To err is a human, 1999, then Institute of Medicine, 2001. They said it's okay, let's try to fix this problem. We have a lot of problems in quality. How to cross this, what we call it بالعربي الهوة, في فجوة, في هوة, between what we practice and what the real quality. So the issue again, the crossing the chasm, and they put a lot of things, how to think, how to treat, how to deal. Quality, like anything new, even if we are practiced more than 20 years, but it looks like anything new. Some people will believe on it. You can argue with some of the people that you can convince them to start quality, but you will shocked here. You will stop here. Honestly, I'm practicing quality more than 5 years now in our hospital, but we're still stuck there. It's not easy to convince the people to practice real quality. There's a lot of causes. Maybe it's need more than one lecture, but the message, if not all the people working with you with the quality, this is a real situation. This is the life. Not all people believe in quality. To be safe, you should have what we call it quality culture. What is a quality culture? How to build it, and which type of culture you have in your hospital. It's different from hospital to hospital. Before that, we should know what is the system. I think all of you know Edward Deming. He's the father of quality. He said that the system is the process and policies, management decisions, training, education, tools and resources, and organizational chart or culture. When Deming talk about the system, he's referring to the entire environment in which people is work, and that's what is included there. This is the system. So how to build the system? We have two problems. First of all the people nowadays, they said, blame the system, don't blame the people. That is it right? That's we should blame the system. That's 85% of our problem is coming from the system rather than from the personal. Some people saying it's 94%, and this Edward Deming said it's 94% of our problem is coming from the system. But indeed, you can read it in different way. That's if you fix the system, you can fix up to 85 or 94% of your problem in your institute. So you should focus on the system. Focusing in the people, this is what we call the blaming culture. Focusing on the system to fix it, this is what we call it non-blaming culture. So again, he's saying if you fix, again, there's no video for that. I think should be fixed before 1 day or 2 days in the conference. It's not accepted, the video is not working in them. You spend a lot of time for that, then you'll, mushkila. Okay, what he's saying that if you fix the system, you will be able to solve 85% of your problems. That's why if you have any problem, any mistake, any medication error, try to fix the system. Look what is the cause in the system rather than to keep blaming the people, and the problem will keep happening again and again. طيب, we have two ends, blaming, non-blaming. Can we have something in between? Balance between blame or not to blame the people at all? Any idea what we call that culture? Just culture, البيئة العادلة. Okay, it's coming. Or okay.
85% of the reasons for failure are deficiencies in the system rather than the employee.
Okay, 85%, and he said 94% even. So there's two ways to think if you have problem. First of all, either to blame the people for any mistake that the nurse caused the problem, or you should come and discuss how to fix the problem because you have a lot of barriers, and this is what we call Swiss cheese model. That you have a lot of barriers before the problem will happen. You should look what you have, problem in the training, problem in education, a lot of things, policy, procedure, administration, or whatsoever. This is the way how to think rather than to come and blame the people. And honestly, I find it extremely nice. He will tell you, we have 30 or 40 nurses covering 40 bed in ICU, and he's wondering why the mistakes and problems happening again and again. You are not looking like a Swiss cheese model. You have a big hole that's the problems can happen daily. So blame yourself, not the nurses. Iceberg, it's very important. If you discover one problem in your NICU, one mistake, that's okay, we have one incident. That's a problem happened there, medication error. Multiply by 10. And you see that the latent failure, it consists of 90% of the iceberg. So you have 10 times the problem is still hidden, and you are not discovering it. So don't say I have one problem. Honestly, you have 10, but you discover one of them only. So blaming, it can destroy the whole work. Non-blaming, it will affect the system. So try to balance in between. البيئة العادلة, just culture. So blaming, non-blaming again, just culture. I'm focusing on just culture because we have a very big policy, but still right now we are practicing blaming culture. How to build the just culture? Educate the staff, train them, and follow the standard. Sibahi coming, we are doing our job, then we forget everything. This is our problem, honestly. Type. There's what we called 10 patient safety for hospitals. I'm going to talk about 10 only because it's going to take time too much. Did you hear about FEMIA? Are you practicing that in your hospital? Anticipating the problem before it will happen. You are practicing yearly risk registry, which I think nobody like it at all. But you can discover a lot of problems before it's happened. This is a proactive way how to discover the problems. We are blaming sometimes the resident or the doctors. They have before 30 hours of duty. But it's evidence-based, and it's issued by Institute of Medicine again. There's correlation between the shift hours and the problems. So if you have a doctor's working for 30 hours sometimes, shift, so you should blame yourself, not the doctor, if you have any problem or any mistake. Focusing about patient safety organization, PSO. Maybe there's different names here and there, but you can say it's like المركز السعودي للسلامة Safety Center. If you are reporting for them, you can get a lot of data, you can analyze, you can learn from your mistakes. Or you can report in your hospitals. So collect the report, get data, analyze it, and share learning with the others. And you can solve a lot of problems. We know that the medication errors is consisting at least 28 or 30%. Diagnostic errors and health care associated infection. If you don't have data here, all numbers would not be clear for you. You don't know how to treat what you have problems here and there. So without data, you cannot work in research, you cannot work in quality. Estimated, it's long time, this numbers, that you can save the life of more than 90,000 persons by following very simple safeties. This is the numbers. Medication error always coming at the top. Following some quality improvement project, focusing on quality, it can save a lot of lives. So if you focus or you start here, you can see that the numbers going over 3 to 4 years sharply. What the benefit of reporting, learning from your mistakes, learning from your errors, that you can build what we call proactive risk reduction, enhanced safety culture, access to expertise. They can help you data-driven decisions, not guessing that we don't have problem. You have a lot of problems that you are not reporting. This is a problem. Performance benchmark, national, or from different hospitals or whatsoever, reduce bigger problems. And honestly, it can help you a lot. So don't waste a good mistake to learn from it. I think all of you, you know what it's International Patient Safety Goal. I'll talk about only one of them. This is what we say about communication. Communication, I think you're not surprised, that's 80% of our problem in communication, and mistake is coming during the handover in the NICU. That's why we are focusing too much on it. There's a program, what we call it Team STIPS. I don't know if anyone heard about it. I put it in the drive. I will send it to you at the end. So this is all the presentation for me. ما أدري هي بالعربي الرجال من الزهرة والنساء من كوكب تاني. يعني ما يفهموا على بعض. ما في communication between them. So I chose the same title. That's doctors from Mars and women or nurses from different place. So there's no good communication between the nurses and the doctors. And this can cause a lot of problems. How to solve it? SPAR or STIPS. STIPS, I think, need more than one lecture, but I will talk about the outlines of STIPS, how to improve that things. Quality improvement projects can help you a lot to improve your safety. I'm not going to talk about CLAPSI because Prof. Saifi will talk about it, but I will remind you if you have a lot of projects to work or to do at the same time, you should follow what we call it 2080. حدا يعرف إيش الرeflection بالعربي؟ في مبدأ إسلامي, it can reflect Pareto. This فقه الأولويات. فقه الأولويات. We focus on 20% which we call it vital few, which can, 5 minutes, يعني, which can solve or fix 80% of the problems. So this is Pareto, what we call it فقه الأولويات. Okay. This is another talk I'll present tomorrow, but it's in Syria, online. Golden Hour. Golden Hour, I think, is one of very known project in equality, focusing on the first 60 minutes of the PABG life and what the things you will do it. Quality improvement project need two things. First of all, working in a bundle and following the best evidence. You have it. Bundle, بيت الشعر تأبى الرماح وإذا اجتمعنا تكسرا وإذا افترقنا تكسرت أحدا. This is the principle of putting all the intervention together. Golden hours can decrease severe IVH, PPD, mortality, admission, hypothermia. It can help you a lot. And this is a golden hour, decreased by 35% of severe IVH. And it's evidence-based, published in Pediatric. There's a lot of quality tools you can use it. We are following Focus PDSA, but Canadian. By the way, we translate the material into Arabic, and we start to teach it in Syria recently. This is one of our projects, fixing the admission hypothermia in our hospital. Luckily, after working for 6 months, we were able to decrease it by 20% only, 6 months. We trained more than 200 nurses, doctors, people, simulation, and it's end by decreased 20% only. So you need a lot of efforts. I think it's reported by Prof. Faleh before, we have 70% of admission hypothermia. We decrease it to less than 30% now after our project. This was our project. Again, المشكلة البوينتر مو دائما. Okay, governance and leadership, I think most of the time is not going to help you, but they should. Do you agree that there's no quality without authority? لا رأي لمن لا يطاع. مقولة علي بن أبي طالب كرم الله وجهه. لا رأي لمن لا يطاع. That doesn't mean you should force the people or push them to do quality. At least you should have organized things from the leaders they can follow, not to pushing them. Nothing can be by force in equality. Team steps, I said I will mention the outlines only. That's focusing on the team training and communication, simulation-based training, checklist, care bundle, collaboration of QI networks. And this is the principles of it, because it's really huge. I'm not going to talk about it in details. It's include team structure, communication, leadership, situation monitoring, and support. There's steps: assessment, then phase 2 planning, training, and implementation, every single step there, and then how to sustain it. Honestly, don't trust AI in everything. I did it last night before I sleep, but I discovered that it's catastrophic, really, the way how View 3.1 even, he did it as a video.
The process begins with
it's full of
phase I
mistake.
assessment,
So
leading
don't
into
trust it
phase
always.
2, planning, training, and implementation.
Most of the arrows is wrong. Sorry for that. So there's barriers, there's tool strategy, there's outcome, how to do it. There's a file, I think it's close to 50 page. I put it in the drive, I will send it to you. Family-centered care. We know that's what is the principles: dignity and respect, information sharing, partnership and participation, collaboration. But involving the family and to be family-centered care, it can decrease mortality, can decrease stay in the hospital, can have a lot of benefits touching the safety. AI in NICU, I think Dr. Jabara will talk about that. So I'm not going to focus about it. Machine learning, how they are predicting sepsis, things, a lot of things you can monitor, a lot of things you can do it in AI nowadays. And you see, to pick up sepsis, it will be much earlier than depending on the routine things. But again, you should have data. Without data, it's useless. AI, research, quality, it's useless without data. Exactly. Good system. And at the end, I believe that the staff, following standardization, building good system, it will end by safety of the patient. And this is a core focus for you in your hospital, depending on the staff to build the quality and the patient safety. So it starts and ends by the staff themselves rather than the administration. So if you are interested to get a copy of my lecture, step, and I create a video of 7 minutes. It's a summary of my lecture. Maybe في شغلة رابعة ما أذكر إيش هي. You can scan the barcode. Sorry. How to discuss this case, I create a PowerPoint of 20 slides, how to approach medication error, especially for this case, what is LASA, how to think about it, how to solve it. There's a PowerPoint presentation. You can find all in this barcode. خلصنا or ثواني. طيب. Any volunteer can answer. When the nurse gives the wrong medication and the baby died, who is the victim? Is it the baby, is it the nurse, or both of them? Nurse. البيبي مات يعني معقول ما يكون victim هو. So it's both of them. And I hope that you will read about what we call it the second victim, to know how to deal with the people rather than to blame them. They are suffering a lot of pressure. We are starting to investigate things, a lot of things, while you need to support them rather than to blame them. Both of them, yes, you are right. So 50% of us suffering from what we call second victim in one time of our practice. This is take-home message. Honestly, how I did it, I gave my presentation to ChatGPT, and I asked him to create take-home message, and it's honestly was perfect. Nano banana, he created as diagram. We are coming every day to do our job, but we need to work on improving it. And quality is everything, responsibility, and thank you very much. يعطيكم العافية.
Thank you very much, Dr. Adnan. We will leave the question at the end. And again, thank you for insightful presentation. Dr. Adnan, he reminds us, as always, that the infection control and patient safety is not an optional. Both are in the heart of neonatal care. So we will move with no further delay to the second presentation. The second presentation will be with Dr. Saif Saif. Dr. Saif Saif, he is the chairman of the Neonatal Intensive Care Department at National Guard Health Affairs. Dr. Saif has a Saudi American Canadian board certified neonatologist with more than 20 years of experience in the field of neonatology. He is the former program director of the Neonatal Perinatal Fellowship Program at National Guard Hospital, Riyadh. And he is the course director of the Neonatal Pediatric Mechanical Ventilation and Conference chair of New Brain, Saudi Arabia. Also, he is the co-director of the Saudi Neonatal Station Program. He has multiple quality and safety initiatives programs. He led the Zero Collapse campaign, achieving 820 days collapse-free in the NICU, and he directed the Zero Blindness campaign for more than 13 years with 0 cases of blindness. Lastly, he managed the neonatal bone fracture program, maintaining a 0 fracture rate among the high-risk infants from 2017 to 2022. Thank you, Dr. Saif, and welcome. The mic is yours.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Yahya, for the nice introduction. I'm pleased to be here today. I'd like to thank the organizing committee and the scientific committee for inviting me to be a speaker in the 23rd Saudi Neonatology Society International Conference. It's a prestigious conference. I'm happy to be here. And also, I would like to thank the organizing committee to choose to ask me to talk about collapse prevention experience in National Guard Hospital, Riyadh. Just an introduction for My talk that I like Dr. Adnan's talk, which give me a lot of easy talk about quality, because it's part of the quality to prevent eclampsia, because it's preventable. And at least 2/3 of the eclampsia is preventable. So I would like to emphasize that to treat eclampsia as an adverse event and need to be reported. But more importantly, to focus on what's the root cause for these eclampsia, rather than assigning blame. If we do this, looking at the root cause analysis, it will open door for improvement for our patient quality. So today I will dive with you and explore how we can achieve this. And we'll tell you our experience in fighting eclampsia. We are fighting eclampsia for the last more than 15 years now. Sometimes it's beat us, and most of the time we beat eclampsia, alhamdulillah. At some point, many years ago, we think eclampsia cannot be prevented. When you see a sick patient, a lot of central lines, manipulation, crowdedness, shortage of staff, still you think it cannot be. Maybe immunocompromised, but alhamdulillah, with the help of Allah Azza wa Jal and the team with you and maintaining the quality, we were able to overcome this issue. So my talk today will be summarized very quickly about what's the eclampsia, what's the magnitude of the problem, chasing zero eclampsia project, experience, challenges, our success, and if I have time, I will just give you some few slides about preventing eclampsia from the literature. So what's eclampsia? Eclampsia, just as a definition, it's a laboratory confirmed primary bloodstream infection where an eligible BSI organism identified and eligible central line has been placed. What's the eligible bloodstream, which it's a laboratory confirmed bloodstream infection, is not secondary to another site. This is an important. An eligible central line is a central line that has been placed and for more than 2 consecutive calendar days, and such line to be eligible for eclampsia events to remain eligible for eclampsia until the day after removal. So if you remove the line today and tomorrow you have a baby with blood culture positive, still we consider it eclampsia. So it's important. The definition changed from the CDC. It was 48 hours from removing the line. Now they make it 24 hours from removing the line. So healthcare or hospital-acquired infection is a major patient safety. 4 to 12% of patients admitted to ICU, they will have 1 or 2 infection during their hospitalization, and more than 600,000 hospital-acquired infection in patients in ICU in the United States. Each eclampsia events independently increase length of hospital stay from 7 to 23 days. This will lead to extra cost, estimated cost in the United States from $35 to $45 billion per year. More importantly, eclampsia causes 70% of all hospital-acquired infection in preterm infants, and among surviving extreme low birth weight infants with hospital-acquired infection have 60% increase incidence of permanent neurodevelopmental impairment, and more than 70,000 patients with hospital-acquired infection died in ICUs, in hospital ICU in the United States. But encouragingly, saying this, that progress report from the CDC revealed 44% nationwide in the United States decrease in the eclampsia rate. How it's happened? The eclampsia is man-made. I think we either extraluminal, that means during improper insertion of the technique, or poor maintenance of the insertion site. So the bacteria migrate, how can I go? Yeah, it's migrate through the catheter and embedded in the protein sheath, or intraluminal, when you have a hub to inject a medication without proper cleaning or omit cleaning of the hub, you may insert the infection to the baby. So this is an important major risk factor for infection. So what's the incidence of eclampsia in neonatal ICU? This is Pang et al. Published a recent article in 2025. It's a very systematic review, a meta-analysis for more than 13 countries and more than 35 studies, collected 35 studies, and they found collectively the incidence of eclampsia from 2001 to 2022, 6.5 per 1,000 central line days. And the range of incidence from 2.3 to 18 per 1,000 central line days. And interestingly, that the eclampsia rate, it's nicely decreasing over the years, as high as 18 per 1,000 central lines and as low as 2.3. But for the last maybe 4 or 5 years, you see it's dramatic decrease in the eclampsia rate that's improved the outcome. In the United States, Sue published an article in JAMA 2020 looking at 132 ICU and look at the mean of eclampsia rate in the United States between 2013 and 2018. What she found that 1.5 per 1,000 central line days, the risk of eclampsia for babies less than or equal 1,500 grams, and 0.7, less than 1 per 1,000 central line days for those birth weight more than 1,500 grams. Interestingly, if you look at the graph here, from 2013 to 2017, there is no major change in the rate of eclampsia. It's static. That's after implementing the central line bundle or eclampsia bundle. The plateau for eclampsia rate maybe lead to consider it's just not expanding the surveillance of the infection of the eclampsia, not just looking at the eclampsia per se, but looking at all BSI, all blood culture positive in your department. This may improve the outcome of eclampsia because there is no change but looking only just the eclampsia rate. So, and in 2016, Roque et al., he published an article in his conclusion that the reduction of hospital-acquired infection has been associated with reduction in eclampsia. That makes us think that by extending the focus beyond the eclampsia bundle or a surveillance approach to surveillance all blood infection may lead to identification of opportunity to improve outcome. And this is what we have done in our center. It works very well. What about our kingdom? Habiba, Mamlakatan al-Habiba. Saudi Arabia, alhamdulillah, Ministry of Health, they start doing the surveillance for eclampsia in pediatric, in neonates, in adults. And Abdulaziz Shiddi et al. And his group, with the help of National Guard Hospital Riyadh, they did a collected surveillance for more than 100 MOH hospital between January 2022 to December 2022. And this data was entered in HISN, Health Electronic Surveillance Network program. And they have 15 maternity general hospital and more than 80 general hospital, and they have 63 neonatal units with the beds, total number of beds, 1,300 beds. What's the result? Our eclampsia rate in the Ministry of Health hospital in the kingdom here is 3.7 per 1,000 central line days. Then they did a benchmark to compare ourselves to the international. Unfortunately, we are a little bit higher than NHSN, National Healthcare Safety Network from the United States, which is equivalent to HISN. Yani HISN is equivalent to NHSN in the United States. But the good thing is that we are less than the Gulf Corporation Center and International INICC, International Nosocomial Infection Control Center, which more than 5 per 1,000 central line days. So we are doing okay, but we need to improve better and better. So, and then, sorry. So what about National Guard? So we have an issue with the National Guard Hospital Riyadh in ICU. We have 40 beds, neonatal ICU beds. It's very crowded. It's not the best area that it's very narrow, it's crowded, it's busy. So our infection rate was very high, actually. From 2008, we have 4.7 per 1,000 central line, 4.3. And if you look at the utilization day, the NHSN rate is 0.22, but we are using a lot of central line and we keep the line for a longer period of time, 0.37. We try to bring it down, the rate of utilization ratio for a central line, but still the eclampsia rate, it's still steady, it's the same, it's higher than international figure. Because NHSN rate is 1.2 and we are more than 3. So how did we approach this disaster of babies with eclampsia that cause mortality, increase length of stay, increase BBD, increase ROP, increase different pathology, the risk of different pathology? Can we move the slide, please? Yeah, so what we did, first of all, we think, as usual in neonatal ICUs or any ICU, the hand hygiene should be improved at all times because it comes from our hands. So we did a very big and hospital-wide hand hygiene campaign that's back in 2009, and then implemented of central line bundle, which just recently was implemented in neonatal ICU in general, because the central line bundle started maybe early 2000 in adult mostly, and then moved to neonatal in 2005 and 2006. So we start implementing the central line bundle. Then we also work how we can promptly remove the central line if not needed, but still after we minimize the use of central line, the rate went down and then went up again. So even our central line utilization ratio was low. So we said, okay, this is the time we have to maybe have a team, eclampsia team in National Guard, just looking at the eclampsia rate, so monitoring the eclampsia central line insertion and monitoring central line maintenance, and 2 nurses always watching the doctor when they are doing their hand hygiene, wearing the gown, wearing the gloves. One of the physicians came to me, Dr. Saif, I changed the gown 4 times. I changed the gloves 3 times. This is waste. I said, no, please, my friend, it's not a waste. The waste, if you have a baby with eclampsia, he may die, he may also stay longer, and he have more chronic lung disease and other illnesses. It was very strict, so this is now we build the culture, because our eclampsia bundle compliance rate was very low, 84% only, and we should be at least more than 95%. So, and again, because the rate is still high, despite we are less using of utilization of central line, more hand hygiene, so we said, let us may have more strict. So we kept our door in neonatal ICU locked, so nobody can go in. The pass to go inside the unit, you have to wash your hands. Otherwise, you cannot wash. You cannot go in. Many consultants got upset, from different specialties, physician, fellows. We said, sorry, this is our policy. Please wash your hand. We are not asking for something difficult. It was not an easy, as Dr. Adam mentioned, changing culture is not easy. So it's well known now in National Guard, in ICU, be careful. You have to wash your hands. You have to wear a mask, etc., etc. So it's a culture. That's it. You have to build it and sustain it. Then in 2013, we start using Curis, which alcohol impregnated cap. This is the green one. So using this one, it makes a lot of difference, in our opinion, because the nurse, before she accesses the central line, she needs to clean it with alcohol for at least 15 seconds and wait for 15 seconds. They don't wait. They just open, give it, and they push the organism inside. And also, we start using this chlorhexidine, 4% chlorhexidine, because what's supplied by the housekeeper, the soap, the built-in soap in the wall, it was shampoo, actually. When I open it and read it, this is a shampoo. It's not something used for a hospital to clean your hand before doing clinical procedures. So, and then we start using the chlorhexidine, which we have a big discussion with the infection control. You know Ziad Mimish? Ziad Mimish is a big figure in Ministry of Health. He was the infection control director. So in their APP, not to use chlorhexidine before 2 months of age. We said, we can't. We have a lot of infections. We have a lot of very sick babies. We need to use the chlorhexidine because it's proven it's better than just alcohol. We are using povidone in the past. So we went, myself and Dr. Hakim, I remember my friend, and went there, we tried to convince him. We said, okay, because we cannot use the chlorhexidine if it's written in the APP, it's not allowed. So the nurses will never use it. They will listen to the APP, which is the policy and procedure for the hospital. So we said, okay, can you change the statement to say, with caution? When he wrote that with caution, alhamdulillah, we start using the chlorhexidine, aqueous without alcohol for tiny babies, before inserting the central line, before putting the IV. And we can watch, it was very, very useful. This one, sterile one, because that one is not sterile, but this one, the one, the fast, they call fast, is sterile one for central line. Always we use chlorhexidine with alcohol. And this, the 4% chlorhexidine also make a difference. So we saw a really a difference in the collapse rate after using this one. Also, we start to maximize the barrier, so the whole baby will be covered, and strict bundle compliance for that one, strict for bundle. So we did a lot of intervention because we spent almost 4 years. We are not moving. Still, our collapse rate is high. So we cannot keep it forever. So we have to do more intervention and more. So we pick line, change dressing. Again, another fight with our colleague. We make the physician, he should do the dressing. Because before the nurse, he will go and change the dressing, but the line will be dislodged. The line will maybe, it's not with a very good sterile, because she will be worried that she will remove the line or the line will be out. So we said, okay, the physician will do it and the nurse will help. طبعا it was not easy decision for us, but this is what we have to do because we have an issue with the collapse rate. Central line insertion procedure stamp before the electronic system. We stamp it, so who insert the line, what time, what's the length, etc., etc. We know what's happening to the central line. So we have a trolley, special trolley, assigned a collapse nurse. So the collapse nurse, that means every shift, one nurse, if the doctor decided to put a central line, she will stand watching from the washing, gowning, inserting, and any breaching for any infection control, she will stop him. She was empowered. And this is another trick. You have to empower your nurses. If you don't empower them, things will not go straight. So we have to empower them, help them, support them, because they are helping the babies, trying to protect our babies. Physician guideline for central line insertion and standardized guideline for nurses to access the central line. Not any nurse, because in the past, to give a medication, they go to the central line, take the hub in the stopcock and push it. We said, no more. If there is a line connected to the pump, at least 1 meter length, put it there. This is for medication. So she doesn't need to go to the central line. She will go in the end of the line for the central line without having an issue. And this will be changed every 24 hours. Because if there is an organism, it will migrate. It will take 24 hours to reach the baby. So we'll move it before it reaches the baby. And then we were very happy. We reached 230 for just 20 days maybe, or for 50 days short from 1 year. We were just trying to reach 1 year with zero collapse. But unfortunately, we have an incident, and then we start again. So in December, and alhamdulillah, in December 15, 2015, we were able to reach 1 year with zero collapse. Everyone is happy. Nurses, physician, and Dr. Noura is here, and I take her permission to post her picture. She allowed me, thank you, Noura, for this. She was a consultant with us at that time. So we kept going on with the zero collapse. We reached 710 days. We were just short from 2 years. We wish that we have 2 years zero collapse, but then we said, okay, guys, you did a great job. Thank you. Everybody was happy. We appreciate their work. So doctor is happy, nurses is happy, everybody is celebrating the events. Everybody, we involve the leaders. And this is a very important. You need to involve the leader to appreciate your staff. So this is Dr. Bandar Al-Ganawi. He came and appreciate our staff for this excellent achievement. This is Dr. Bandar Al-Ganawi. This is his deputy, CMO, Dr. Saad Al-Mihraj, our medical director, and the director of infection control in National Guard, Majid Al-Shamrani. So this is a big difference for our nurses and our staff, physicians. So this is our colleague, Dr. Khawaji, and we are there. This is our chairman, and this infection disease consultant. So we give away mugs with the 710. It was a big event for us. We never think that we will reach 710 days, never. So we said, okay, now we are able to reach, let us reach 1,000 days. So we work hard. Unfortunately, after 710 days, we have 2 collapses in 1 week. Imagine. Then we stop. No more collapse. Alhamdulillah, we reached 838 days. And we were planning to have 1,000 days, but we couldn't. So we celebrated the 500 days, zero CLABSI back in April 2018. Our nurses very happy, our doctors very happy. So everybody's happy. So you see the whole team involved. The whole team work with you to help the patient. This is important to achieve any quality improvement project. You have to involve the team. You have bring their morale up. Talk to them all the time. Show them their achievement to make a difference for continuing and sustaining your quality improvement project. So just to show that we are not doing great in the utilization ratio, it's above the NHSN rate, which 0.22, but still our CLABSI rate is good. So we are not bad in the CLABSI rate despite we are utilizing the central line more. But look at the improvement in the compliance bundle. It's improved. This is what caused the difference. And then we did some statistical analysis about pre and post intervention. Pre the intervention, 15 CLABSI events within 4 years. But after the intervention, only 3 CLABSI events, which give us the rate 0.3 per 1,000 central line days with a statistically significant. And this again, CLABSI event statistically significant, and the CLABSI rate was statistically significant before and after the intervention. So our zero project in National Guard, it's a really big, long journey. So this is what we have a problem. Then we reach 710. Then we have an CLABSI. Then again, 838 days, zero CLABSI. Then we have an infection. We again went up to 820 days. We were planning to celebrate, but unfortunately, COVID came and stopped us from doing anything. But we have an issue during COVID and after. We have a lot of nurses, they left us. Many RT, they left us. We have severe shortage. We got very busy from 2021. Then after, we have some issues with the CLABSI. If you look at the graph here, it's up and down. So in 2021, suddenly we have 6 cases of CLABSI. What's going on? We were shocked. What happened? From 0 CLABSI to 6 cases in one few months. So when we looked at the culture positive during our in the hospital, so we looked in May was 5 cases, 1 case of blood culture, but other culture from tube and urine. And then in June was 11 cases, 6 blood culture positive. And then in July, we have again another 6 blood culture positive and 9 from the tube. Different organisms. It's not just one, it's different organisms. We don't know what's going on. Then we, again, as usual, so out of 17 blood culture positive 6 cases, yani 35% of these our blood culture positive cases, 6 was CLABSI. Acinetobacter, Staph epidermidis, Pseudomonas, Enterococcus faecalis, and Staph aureus. So it's not outbreak actually. So we think what's going on. So we have a meeting, multidisciplinary task force with the infection control. We said we need help. We need to go and see what's going on. So we look at the root cause analysis. What could be the issue? Where is the problem? We met with the infection control. They wrote the recommendation. We distributed to the healthcare provider. We talk to each other. We are meeting every week about what's the progress of our infection, and we change the practice. So then we look at the, as usually as inequality, fishbone analysis, practice, hand hygiene was breach. We are not using the appropriate disinfectant. As we said, they are using shampoo. In the unit, we said no more, use 4% chlorhexidine to improve the cleaning. And the supply, during the COVID, there is a lot of problem with the shortage of supply, shortage of cleaners, shortage of this. And also in the same time, the administration, they are telling us, okay, we will move next year to new hospital. We will move, so we cannot buy new equipment, we cannot buy too many things just to improve our the environment and quality. And then also we look at the staff. They are washing their hands, they are using alcohol rub, but within not at the optimal time, which 20 seconds at least. Also shortage of CRNs, which clinical resource nurses, shortage of nurses, shortage of respiratory therapists. And the respiratory therapist was not part of our huddle before this event. So we including them, we are asking them to be with us to hear about the infection happening in the unit. Then we look at the environment. Our unit was very old. We try to improve. We are moving, so we are waiting for the movement. We did not do a terminal cleaning for many days, many years, actually since 2020. So then we found something else. We found the sink. The aerator was very dirty. It's really ugly. If you look at this one, very ugly. And this is the whole, when I saw one, I went to the whole, all the sinks in the unit. This is the faucet, all of them like this. I thought maybe when we are washing our hands, it touches this area and taking the infection with us. This is why it's different organism. So we did the culture for this aerator and we found the same organism that we are facing in the unit. So we asked to change the faucet and the aerator in a monthly basis. I mean, the faucet will be a new one, but the aerator, this one, we need to change it every month. Even we tried to find it in the medical market, we couldn't. We found it in Sacco. We bought all what Sacco have, maybe 200 ones. They said, get it us. We'll have it every month to change it. We have almost 20 sinks, so every month we change it to make sure it's clean. So what happened? So this is when we did the root cause analysis, knowledge deficit, we are retraining and re-education, breaching the hand hygiene. We have strict monitoring for hand hygiene, and one refused to do hand hygiene will be reported to the quality. So SRS will be raised, it goes to quality, quality goes to infection control go to medical director will come to us and ask what's going on. Why this medical or nurses did not wash their hands, what's their objection? So assign 2 nurses to audit during procedures and increase number of new nurses in the unit, so we need to make more extensive education for our nurses. More teaching, more practicing for hand hygiene. Crowded in the unit was small, as we said. We say, okay, not everyone will be joining the rounds. Maybe some of the people that are not needed. We don't need 3 RTs, we don't need 3 pharmacists, we don't need even medical students. We just take them away a little bit from neonatal ICU. Inappropriate cleaning and disinfection of the equipment. The BCT, the patient care technician, were cleaning the equipment, and the housekeeper was cleaning, but they are not doing it the right way. So we start to audit them. And shortage of clinical educator. We train the senior nurses to be a clinical educator, and also high turnover respiratory therapists. Many respiratory therapists moved, and now we have to train again the respiratory therapist. So we're changing the aerator every month, and you look what happened. The infection rate went down significantly. From here maybe 21, 11 to again 6, 9, 6, 2, and more than this, 0 CLABSI. From 6 CLABSI 4 months earlier to 0 CLABSI 4 months later with this extensive intervention. So we need to work hard and extensively to protect your babies. Then, alhamdulillah, in September 28, we moved to the new hospital. It's a really nice hospital called Women's Health Hospital. And it's a very nice, this is our physician, everybody's happy, our fellows behind the screen, you can see them. And this is a 60-bed neonatal ICU and 34 step-down beds, which 96 total. We serve 22 weeks or above, very high-risk patient. We have a lot of high-risk patients coming from everywhere in the kingdom. We have almost 9,000 delivery per year and more than 1,000 admission after we moved to the new hospital, because it's a new hospital and people, they start to know about it. So it's different. So last year when we moved in 2024, we have more than 1,000 babies admitted to us. This is a new ICU. This is the entrance. The family will wash their hands, wear the gloves, wear the mask and the gown, and we always promote breastfeeding. Breastfeeding, it makes a difference. Even you don't have enough milk, you just put a milk in the cheek of those babies, it improves their immunity. And we see a big difference, subhanAllah, for feeding intolerance, for infection rate less, length of stay less by just promoting breastfeeding. So when the mother comes, she will read this one encouraged in addition to our encouragement. So this is the unit, clean unit. Big distance between the bed. It was before maybe 1 meter distance. It's just adjacent to it, but now at least 2.5 meters. 5 minutes. Then with this nice clean unit, which designed based on our need, unfortunately we found a mistake, which having the sink inside by the bedside, and the sink is not at the standards. It's very shallow. So we said, close this sink, don't use it. But when? We didn't discover till we have the problem of the infection. So this is our rounds, spacious. We have the fellows, the consultant fellows, RT, pharmacist, dietitian. And this is our team also. We are happy. This is our fellow putting the insertion central line. 2 nurses to hook the tib in. And also when they change the tib in daily basis, we should wear all the BPU, make sure that you use sterile gloves, sterile gown, not sterile gown, and also sterile drape to make sure nothing touching the baby, so it will be done under sterile technique. So what happened? Only 1 month after arriving to this new hospital, we have 6 cases of baby with Klebsiella. Not Klebsiella, sorry, Pseudomonas aeruginosa. Pseudomonas aeruginosa. 2 from the AT tube, 1 from the eye, and 3 cases from the blood. And unfortunately, we lost 1 baby. 1 baby died due to the Pseudomonas infection. So we said, oh my God, what's going on? So we think maybe the sink that's making the problem, so we stopped using the sink. And this is 2 cases CLABSI before we move, and 1 case when we moved to Women's Hospital. And we did the fishbone analysis. It's less because we have a new hospital. Everything is done in a very well way. So practice breaching hand hygiene, inappropriate use of disinfection that I show you. And then supplies, hand wash was not appropriate, so we added more. And also the doctors and nurses, they are not using hand hygiene more, and we have shortage of staff. And mostly environmental, when we found the sink is shallow and splashed the water around the baby on the beds. So the multidisciplinary and root cause analysis came up with that the sink may be causing the issue. So we stop using the sink and add Avogard. Avogard is a chlorhexidine with alcohol. It can be used for even before the procedure. We learn it from the OR when we go to L&D and we rushing to see the baby inside. They are using the Avogard and go for cesarean section. So we said, okay, because we cannot use the sink, we need to use something maybe equivalent to hand hygiene. So this is the Avogard. We put it everywhere before entering the room and in the bedside almost. And this is what they are using in the cleaning from housekeeper. So we added the chlorhexidine here to make sure that it's really disinfectant. And the shallow sink, this is outside unit. We added a bigger sink with the deep so the doctor can do the hand hygiene and can do their scrubbing before the incident. So what we found, this is our rate of bloodstream infection from 21 to 24. And you look at the rate for all base eye, 1.2, 1.2, 2%, and then 0.8 when we moved to Women's Hospital. So there is a significant drop in the rate of BSI, mainly in 2024 when we overcome the problem. And the CLABSI rate, it was 6 in 2021, 22.3, 23.3, and 2 in 24, and make us our CLABSI rate over the last 4 years is 0.7 per 1,000 central line. In 2024, it was 0.4. So our rate is acceptable. We are striving for 0, but still we need to improve better. So as of the first quarter of 2025, we have 2 cases of BSI, Enterobacter homanchi and Enterobacter kewaki, and the rate 0 CLABSI in the first quarter. But I will tell you, from the last CLABSI, we have 530 days from the last CLABSI we have back in April. So this is our journey. We have a bad incidence of CLABSIs here back in the 2013, 14, and then we improved, till we reach this stage now, and we are doing better. And the same picture we show from Dr. Adnan, always you see the tip of iceberg. So multidisciplinary takeaway message, multidisciplinary involvement is important. Consistent reminder, re-education, training is essential. And auditing, this is what is my experience here, auditing and monitoring surveillance for all BSI, all infections. Every week we sit together as a team and discuss many issues. One of the issues, the standing issue, is infection. So how many babies we have culture positive? Regardless, blood, eye, wound, respiratory, what's the culture positive? So we are monitoring every week because it makes a difference to manage your patient. If the patient got sick, you know what organism you are dealing with and what the sensitivity, and also monitoring CLABSI, which make a difference in the rate of CLABSI. And small changes make a huge difference. So what you see, the success, but what you don't see, the failure, the disappointment, the sacrifice, the persistent, continuous sustaining of monitoring, disappointment, hard work, and dedication, more discipline. So again, to improve your quality of patient care in your unit, you need to involve all your team in your quality improvement project, sustain it, monitor it, show your team their result, because what they do, it's their work, it's not yours. You are the leader, but what they do, it's there. So they will be happy to see their outcome. And I will stop. I thought I have time to talk about prevention of CLABSI from the literature, but I will stop at this time because not to exceed the time limit. Thank you very much.
Thanks, Dr. Saif. Always give us powerful insights on how structured teamwork can result in measurable safety outcomes as usual. Next, we'll have Dr. Abdul Hakim Gattan. He didn't want us to say a lot about him, but to me, he's the legendary Dr. Abdul Hakim Gattan. He's a leader and a neonatologist at King Faisal Specialist Hospital. He's been involved in many national improvement neonatal care services. Today he's going to talk to us about quality improvement in respiratory care to complete building our safety culture in the NICU. تفضل دكتور عبد الحكيم.
Assalamu alaikum. Just a small request from the people. They said, can you come front a little bit? Those empty tables, better to fill it. Try to come nearer to the stage. Assalamu alaikum. Sabah al khair. It's nice to be here with you this year. And I think the society also would like to apologize for the last 2 years that we couldn't, do the annual meeting here in Riyadh. I'm sure some of you miss it. My presentation today is about the quality again, and you will hear about quality for the next, for the whole era you will work in the NICU, but quality is important. And I will talk about the respiratory care issues, about in the quality in the respiratory care of a newborn. Can we have the first slide, or I can have it from here? You see? I think the quality is coming with us in all aspects of our life. We need quality education, we need quality food, quality sleep, quality everything. We wish to have in this city also quality traffic, though it's very bad. What happened? Apparently we have a problem of receiving my presentation, though I sent it last night. Anyway, so hopefully we can present it soon. But as we're saying, the quality will be part of our life Actually, we are, every day looking for a better quality housing, living, and so on. So I think no exemption, and no doubt that medical field need really to concentrate on the quality. And the quality of our work is saving life, decreasing morbidities, lower down the mortalities, and actually, it's involved all type of medical practices. So here we are, like, I think it's the move from everywhere. I think at all levels and at the administrative level, that quality should be part of the, our curriculum and one of the early items in our agenda. I don't know if they are teaching, quality in the medical school, but I think, it should be also. That, we don't only diagnose and treat, but during treatment, we look for opportunities to improve the type of our, intervention, the arrangement, the devices that we use. And I think this is, forever, it should be, our talented to do that for, a better, service and more, efficient way of doing the system. Nonetheless, we are seeing this quality improvement for the last few decades. Since I started the fellowship in neonatology, now it's about 3 decades or more. There was a lot of steps, and those steps are you may see that, or you are living the benefit of those steps. But at one stage there was, as you remember, I'm sure you are aware, how much, the drop in the neonatal mortality, how much, we are saving babies with a good quality of life, including those tiny babies, the movement of the, viability age, from down when we were in the medical school, they were telling us anything below 28 weeks is non-survival, and you should not look after them. And now we are moving down to 24, to 23, and people also talking about 22. And so I think it's something that we should, beside knowing that it is happening, is to embrace on it. Teach our new students, new doctors, we should teach them that they should look for the quality in their work, not only just to do the work. So we'll try to go over some the identification, evidence, and bundle approaches and implementation. This is a general type of things. So as introduction, as I said, providing appropriate, this is in particular about the respiratory care. To provide the appropriate respiratory care of neonate is very essential to minimize complication, and the intervention decrease the risk of the lung and the brain injury, and particularly in premature infants, and reduce the mortality. The interaction between the intervention in respiratory issues and the outcome and long-term benefit for those patients and their IQ, their developmental stages later on is well known and well studied. So reducing the neonatal mortality and improving the quality of the life for the survival. Now this is some of the old slides that I have. For a long time I didn't see those type of X-rays with the severe pneumothorax or tension pneumothorax. And, for our new colleague, and, you may not saw this for a long time, but that was sort of daily happening in our units before when we were in training. First thing they teach us when we go to the NICU is how to drain pneumothorax, okay? Because draining pneumothorax was a major issue. So this system on the left side is how to drain simple. But it was hung beside every baby bed because we know while they are in ventilator, they may pop their lung at any second. And then that, usually take maybe a few minutes to cause them severe hypoxia. And if not treated, it may cause them even death. So this was a very important way to drain the pneumothorax immediately, even before X-ray and, before you do a lot of investigation. Even if they pass through the pneumothorax stage, then they will go to this stage, the stage of chronicity. And, to see this bad lung, destroyed lung, no wonders, because the way we were ventilating them, the amount of oxygen exposure, the amount of, all the offenders that happen to the lungs, end by severe lung damage, and a patient who doesn't want to improve, and you may lose some patient, and we lost a lot of patients in the past because of that, especially those very low birth weight that exposed to a lot of ventilation. That was our tools 3 or 4 decades back. This is called secrets. Simple, 3 knobs, pressure, can give a lot of pressure, can cause a lot of pneumothoraces. So you need to survive with it at that time. Beside it is the incubator. And you can see simple incubator cannot maintain the temperature many times, cannot maintain humidity. And then at the end, you will have a baby who's getting dry, acidotic, and then you try to ventilate him to compensate. And of course, during this procedure, you destroy his lung. And then you end by severe lung disease. And now this is the progress. This is the quality care now. We have 8,000, baby log ventilator that can, with the simple, touch of the knob, you change it from one mode of ventilation to another, to high frequency, to very gentle tidal volume, targeted, and so on. And to the more advanced incubators that more efficient and save a lot of lives. So the quality of our equipment is very important. And I think this is, you can, should recognize it as, times go by. So it's an imperative and embarrassing that the continuous quality improvement in the NICU from 1960s to 2020, there is major advances that happen. Beside, the administrative issues, and beside the surfactant replacement, the new modalities of the ventilation and the support, all these lead to significant improvement and reduction in the mortality and the morbidities of those tiny babies. So it's a complex issue. About respiratory, it's a complex. You can see that there is, now a lot of different ideas how to save the lung. From non-invasive, from LISA, from mist, from, of course, different or early CPAP management, avoiding positive pressure ventilation in the delivery room and so on. So this is, this role, to define the problem is very important. So it's not only the ventilatory setting, it's the infection, it's the airway obstruction, the lung development, and it's multifactorial issues that, your goal should be knowing all these factors to implement non-invasive strategies that reduce mechanical ventilation exposure through standardized evidence-based protocols. So this is, in short, what we want to do in the current and in the future, and to improve our ways of looking for how to deal with those patients. So there is increased, now as you are aware, that there is increased trends to improve the non-invasive ventilation modes. From straight CPAP to non-invasive ventilation and synchronized one to high frequency nasal ventilation and many different things. So these different ventilation modes need to be studied well, and there is a lot of study going on around it. And to choose the best, depend on how good you are in doing it and how you're going to target it. And I think this is what we will talk about in the way of how to apply some respiratory changes in your team, in your unit, to make things, to make things better, and to upgrade your unit to be more of quality care rather than just to make them survivors. So I mean, the key ingredient for success in these issues will be to have everyone to be involved, to have willingness from the unit, and their ideas should be based on some previous studies from published articles. What is going on? Can we do this? Can we apply it to improve our patient care, and to delivery, and to be consistent and to improve the quality? So at the end also you need to report such type of work. So in the quality improvement framework, as you're aware about it, it should be the aim. What is your statement? You should state your aim very clearly. So what you want to improve, and how you want to improve it. The degree of improvement also important. I want to reduce my patient rate of pneumothoraces from 3-4 times per year to 0. Let's go to 0 pneumothorax rather than only than the driver diagram. There should be some schematic way of doing things, and then you go through one of those known cycles for quality improvement. BDSA cycle is one way, and this is the BDSA cycle, where you have the plan, do, study, and act. And I think it's simple, and it's made simple to make life easier. So for plan, you need to define exactly the problem, and then how you carry it in the do, and then how to study it, what type of data we will collect, and based on this data, we will act. And this act will mean maybe some protocols, some guidelines in your unit where you can make things better. طيب, is this studied, the multi-type of intervention? It is, yes, and it will improve the overall outcome. So in pediatrics 2016, there was this publication of 100,000 babies. They were all small, very low birth weight, that the program to be implemented, multifaceted quality improvement program, where you can incorporate in their management to improve their outcome. And I think this is important. In the respiratory aspect, which is very important, as you know, we maintain them alive many times. طب بعد قدر الله إننا we respirate, we ventilate them, we support them. And how much of support we are giving? Are we giving harm with it? So all these things should be put in mind. And so this is suggested respiratory care bundle that I think most of you, if not applying all, but applying most of it. But to apply it as a one bundle, I think it will make also more pronounced outcome benefit. So to defer the cord clamping, and this is well studied and well known now, to early nasal CPAP rather than to intubate and ventilate. And we are talking about very low birth weight babies, less invasive surfactant, and early caffeine, and the standard care. We'll go over these issues by one. So how to measure the plan, how to the measurement, the process. So this deferred cord clamping, the percentage of eligible birth receiving 30 to 60 seconds of delayed cord clamping, how many of them, early CPAP, and the percentage initiated on the proper setup, and the less invasive surfactant usage, how many times we use LISA or MIST, and caffeine protocol. Then you apply, like, your, for example, BDSA example for the deferred cord clamping. So you will plan it, you will do it, and while you are doing it, you need to know also that there should be involvement of obstetrician, and many times I'm sure your obstetrician will be the one who cut the cord immediately without thinking of timing and so on. So you need to discuss it with them and to try to apply it with them, even in the phase of planning of the intervention, to do and to study the outcome and then to act and to make it as a protocol for your unit. For example, the early CPAP in the delivery room, to do, like, indication usually of the CPAP, to put a clear indication when to apply CPAP, and it should be started, for example, to babies who are spontaneously breathing, even if they are tiny. Now, even the extreme low birth weight, we go for nasal CPAP without using intubation, and giving them a chance if they are doing the effort. So to, like, what type of sitting, the target SATs, and starting FiO2, and the equipment setup. You need to have a good and reliable equipment in the delivery room, and tested well before even the delivery. What else, like, in the process, you need a multidisciplinary team governance. To have people, like, to agree on something need a lot of effort. And I think from the previous lecture with Dr. Saif, we learned that, to do a change, you need to do a lot of discussion, a lot of communication, a lot of, like, communication between the team itself, how to reach a better way. So the core team, neonatologists, the nurses, respiratory therapists, obstetric, anesthesia. Also, we have support team. In case if we have drugs, you need to be given the infection control, like, in the hospital, and so on. Even the biomedical engineering for the equipment. This equipment sometimes get, not working proper. So you need somebody who are efficient and will fix it on the proper timing. And the leadership. The leadership, of course, will help, to sit all this together and make things happening. For example, for the aim, how to set at the aim, for example, for a patient, delivery room management, to reduce the mechanical exposure, mechanical ventilation exposure, to avoid, like, intubation. So you can put an aim that, within, like, 3 months or 4 months, we will reduce the intubation of extreme low birth weight by 30%. And how to measure this, how to have the safety requirement to have it, and so on. So you set your aim during the planning, so it will make it much better and much easier to reach your goals, which should be defined before you start. So the outcome, mechanical ventilation exposure for bronchopulmonary dysplasia. What is the outcome that you will measure from this intervention? You will measure the exposure to mechanical ventilation, bronchopulmonary dysplasia, home oxygen at discharge, or length of the stay of those babies. All these things need to be, like, looked at. Then, you can, discuss, like, how to reduce, like, the rate to, for example, of pneumothorax to less than 2%, the severity of IVH to less than 15%. And of course, you need to keep in consideration what is your baseline results, what is your baseline data. If you have high rate, for example, of IVH grade 3 and 4, let's assume 25% in extreme low birth weight. If you reduce it by 10% within the allocated time, that's a very good achievement. So you need to have a reasonable, goal, and to go for it, to reduce NIC, to reduce all the complications. I'll give you some example of, the intervention that we did at King Faisal in our unit. We are smaller than National Guard unit. We have only 30 beds, but we try to utilize the mist as a way to give non-invasive way to give surfactant, so to reduce the exposure to mechanical ventilation for those tiny babies. So all those babies, they were very low birth weight, and we managed, initially we start to use the mist in the 2018, 2019, but not in consistent way. It was sporadic cases that we use it, and it was deferred to the preference of the consultant, the one who's covering, to give mist or just to go for insure. We were doing insure before that. So then, we decided to make it more practice. So there was some training for our senior, neonatology team, the assistant, the fellows. There was a training to do it, and we start to do it more frequent by 2021, where we have a lot of patients that we give the mist through we give surfactant through the mist procedure. And you can see here in number of patients received surfactant via the ET tube was 61 in 2020, but in 2021 it was 42, so it's less. But the number of people, or of the very low birth weight that receive surfactant via mist on the second year, which is 2021, it was 48, compared to only 2 receive it through the insure technique. So there is clear increase of number of patients receive surfactant through mist procedure. During doing the surfactant through mist, there is some patient that they don't tolerate it. And the number getting less, we treat them, we pre-treat them with some atropine, small dose, actually half dose. We treat with atropine to avoid the bradycardia, and we treat them also with some sedation. Initially, it was full 1 microgram of fentanyl per kg for tiny baby. Then we decide to lower down the dose to a smaller dose to avoid weakness of their respiratory effort. But overall, things improving. And so the instrumentation, which is the special catheter to put the surfactant in the trachea, is not available in our unit. So we are using just the angiocath. And I think I have So this is the angiocath we use, and because there is no numbering over this angiocath, we decide to put a small tape or sterile strip over the sides, how far we should put the tube inside the trachea. And that was done usually by the using we were using the laryngoscope, and some of our colleagues, they like to use the video laryngoscope that they can do it under the video procedure. Then of course it is done while we are using the non-invasive ventilation or CPAP, and usually it's with RAM cannula. And the mist was delivered mostly in the NICU, though there was some few incidents that the doctor decided to do it inside the delivery room, and it went smooth and there was no problem with that. This is the recommended, on the right side of the slide, this is the recommended, catheter, which is made for this purpose, but we use just the usual angiocath till we buy the new catheter. So, non-invasive delivery of surfactant is one way to go, and there is some information, there is some studies that showed improvement in the outcome, and I think it may become like a regular process in our units. So this is a report recently published in the British Medical Journal, I think, and though the number of babies is not that much, there was 32 in the invasive one, versus 57 in the ensure type of delivery of surfactant. It's from one unit in China, and this is their representation of their data, where they have the duration of mechanical ventilation not much differ, and the duration of oxygen therapy also not that much differ. But when you look for the rate of bronchopulmonary dysplasia, though the number is small, and they admit that, but there was some reduction from 36% to 31%. And this, in the bigger scale studies, it may show a better result and improvement. Another study also, but this is not in delivering surfactant, but in a different mode of ventilation of those babies. This is also a recent one, published this year, I think July. And basically they are this is a multi-center study from China, involved 342, all of them extreme low birth weight. So it's really a big study, talking 24 to 28 weeker. And you can see their analysis of different item of care showed a preference of the high frequency. Initial high frequency nasal high frequency ventilation for premature, extreme low birth weight. So for both, there is no treatment failure, more towards the better outcome in the high frequency group. And so the conclusion of that study was saying it seemed to be superior than continuous positive nasal pressure, and it will reduce the need for intubation. And maybe we'll see more towards that way of intervention. In our unit, we use high frequency nasal ventilation, but we use it on selected cases where we have difficulty to maintain them with regular CPAP or non-invasive ventilation through nasal cannula. So I think, again, back to this study, you see there is a lot of intervention that we do after delivery, at the time of delivery, in the delivery room, in our NICUs, that affect the outcome, respiratory outcome. So all these issues should be kept in mind, and we should work to improve the service that we're giving for those babies. And of course, there will be more studies needed in the area of lung recruitment and monitoring, and the technique of the administration of surfactant, and also in the synchronization. And all of these, though it can appear to you small or partial effect, but if we add it together, I will finish soon. If we add it together, I think it will make a difference. So the multifaceted type of quality improvement in our care should be considered, and we should aim for it in all our unit. Thank you.
Thanks for all the speakers, for the insights on all kind of quality and safety in the NICU. Would you please come to the platform to receive questions, please?
For the sake of time, we will have 5 minutes question and answer. Can we have the mic there, please, Professor Miller?
Thanks for the speakers. And I will make one question for all of you. I don't know which one will hold it. When you talk about quality of life, sometimes when you have problems catching the quality, you need a very transparency in the reporting it. For example, medication error, occurrence of collapse. What is that transparency or شفافية في reporting such problems to improve our quality? Abdul Hakim, BBD and Lisa, BBD and non-invasive, it doesn't show that much dramatic reduction in the bronchopulmonary dysplasia with all this intervention. In your study, although the number is very low, very good reduction, almost 50%, صح? So how you can compare your global conclusion that there is no really reduction and between your study that we have 50% reduction in BBD?
In our work with the MIST, it have been, collected and we drafted as a presentation, but it's not published yet. Our rate in our unit for bronchopulmonary dysplasia for very low birth weight is a low one. We are talking about low 20%, 22, 23%. So we are not seeing a lot of chronic lung disease. Can this, intervention of minimally intervention used by surfactant through MIST, can it reduce the bronchopulmonary dysplasia farther down? I think this is what we should report to you in the next year or the next 2-3 years. We will collect all these data and we'll let you know. But definitely I think it helped. Why? Because most of the time when we use the insure technique, the tube stay there for 12 hours to 24 hours, sometimes 2-3 days, because people, they will be afraid to remove the tube. So, but when you use this technique, we see a lot of babies within 12 hours, their oxygen requirement went down. They didn't need intubation or avoid intubation from the beginning. And I think they do better. So over accumulative data, hopefully will show better outcome.
شكرا جزيلا بروف. الصراحة هي المشكلة في reporting in general in the hospitals, the way how you use it and the way how they investigate the problem. So right now we are hearing the people, if he get upset from any other person, he said write OVR against him. He's looking to it in a way that it's like a punishment. He's trying rather than to fix the problem or the error or the mistake, to find the best solution to avoid it in the future. He's trying to personalize the problem that he's complaining against X person. And honestly, to the degree that we report one case before, we wrote OVR because one of the operations is cancelled. It's major, we intubate the baby, we prepare everything, it was neurosurgery. And I asked them to write OVR just in the future because there is a lot of operation after we intubate the baby, prepare everything, and they cancelled all of a sudden. The consultant himself came shouting to the NICU, why you are writing OVR? What we did? You should ask us before we write OVR. I told, sorry, we intubate the baby, we told the parents, we prepare everything, we are about to shift the patient to the OR, but it's our right and the patient right and the family right to avoid such a problem to happen in the future. Even though he's not convinced, because again, on the other hand, or in the other way, the people, they will look at it, the way they will investigate, they will call the doctor, they will investigate as if he did crime issue. It might end by punishment of the doctors or nurses or whatsoever. And I still remember one of the nurses, I'm sorry to say that, she gave them the medication twice. It was hepatitis B. And she is the one who reported herself. So I called, I was acting head at that time. So I asked the people if it's possible to thank her, to give her something that's to appreciate that she's reporting even herself. But we end by the nursing office. They gave her final warning letter and threatening that she might lose her career or it's under supervision for 6 months. And next day she came with the other nurses. They came to me crying because you told us, you encouraged us to write, to report, even to the degree we report ourselves. And next time we will never report any case. And honestly, I tried my best. After a lot of communication here and there, we removed the warning letter. So it's both how we are looking ourselves to the problem, and the other people how they are looking to fix, rather than to fix the problem, how to punish the people. Thank you very much.
One more question.
Assalamu alaikum. Many thanks to all speakers for their inspiring talk. My question is to Dr. Saif, because I believe that we have to take what you have done and achieve seriously in each step. One of your slide, you have mentioned you are doing weekly dressing by physician. And by CDC recommendation, it's not indicated unless something, so you have to do the dressing. But we have to respect your data and the outcome. So do you do weekly dressing even if it is not indicated?
Thank you for the question. Yeah, you are absolutely right. I have the same question from our colleague, but we have an issue with CLABSI many years ago. If I agree with you. All the CDC, all the recommendation, even INIC, which International Nosocomial Infection Control Consortium, they are saying you don't change the central line unless it's soaked, wet, or dirty. And we are using central line cover with the transparent dressing so we can see it. The worrisome from neonatal ICU changing the dressing every week from abrasing the skin. The skin maybe is sloughed or something. But we are trying to go with the policy because if we leave it till it becomes dirty, wet, or soaked, maybe will be missed by our healthcare providers. So we just continue with the policy. We did not change it yet, but we are thinking to change it and watch. But we are afraid. We don't see CLABSI. But I totally agree with you. It's not a recommendation from the CDC or even from an INIC recommendation. Even the European, the Manzano, he published a paper just 2 months ago reviewing prevention of CLABSI. Mention it clearly, not to be changed. For adults, maybe it's different because they have a thick skin. They will not be scaled or become irritated by changing the dressing on a weekly basis. Thank you.
Any more questions?
Just simple comment for that. The beauty of quality improvement projects, that's, as we say in Arabic, أهل مكة أدرى بشعابها. That's even you have 2 hospitals in the same place, that doesn't mean they will follow exact things totally. So if I believe these interventions might improve our cases, I should follow, even there's no strong recommendation for that. It's totally different from research. And the other issue, you have a lot of quality improvement projects, they are not following exact bundles. So there's 2 publications in pediatrics. One following, still using indomethacin for IVH, and they put it part of their bundle. And the other one did not follow. And both of them reached great. That doesn't mean what they put there, I should follow 100%. And this one may be weak evidence, but I can apply it because I believe in my situation is different from Canada and the USA or whatsoever. So it's not copy-paste from the others. Thank you very much.
Take advantage of being here. One thing that fits all, لما الدكتور عدنان قال لا يتبع من لا يطاع، لا يطاع من لا ايش حضرتك قلت؟ لا رأي لمن لا يطاع. فهو الفكرة من فين نجيب اللي يطاع اللي حيأمر كل هذا كله؟ من أين يؤكل الكتف؟ والله يعني we all know this. We have to have power. إحنا we're consultant. I know we have power sometimes, but it's not اللي يطاع. I want you all, and we don't have time, I want you all to reflect on this. يعني what's the best strategy to maintain gain over time? يعني you all had gain, ما شاء الله تبارك الله, in your projects. but how to maintain gain over time.
I think if you allow me just to comment, first of all, you involve your team in your management, in your quality improvement project. Second of all, have a frequent meeting, show them your outcome. This is your work. This is what you have done. Thank you very much. We appreciate. Third, involve the high authority. If you involve the medical director, even the CEO, it makes a big difference in the team. They will listen. They will say, oh, this is a big issue, so we have to keep it and maintain it. And this is the way, this is what I follow the strategy, and it works very well, mashallah.
طبعا الاشيو هنا انه do you need to be a head of unit to do these changes? I think if we feel responsibility, all of us at the level of we know what is the, let us concentrate on the patient and the outcome of our patient as a unit, as a worker in this unit, from the nurse to the doctor to the respiratory therapist. If we concentrate on the patient outcome and that we are here to do this job, to do it, I think it will be easier to find somebody who to lead us. But if somebody, wants just to go with his own mind and do whatever he wants to do, will be difficult to control. Even if you have a good head section, he will resign next week.
One last question here.
Okay, shall I answer or? Just a simple comment. There's different levels and argument how to convince the people. Administration, you can convince them by saving money, mainly. And your colleague by looking at the data. Nurses mainly will be convinced if they see the result of the patient care. And to have a project like IHI saving 100,000 death. In 2006, they convinced more than 320 hospitals across the USA to save the life of 100,000 babies. How they did it, there is special approach. They call it Cotter way. And the way how to approach the people, it's a systematic approach, not only single intervention or whatsoever. But at the end, really, you are right. Always saying or telling my colleagues that's really practicing quality, it's need sabr ayub, حقيقة, to be able to continue to convince the people. As Prof. Saif mentioned that they stay for how many years now? So not to start by 2 to 3 months, it's, I fed up, I tried my best, and you should try for years, not for a few months.
For the sake of time, we have one more question here, last question.
Okay, for Dr. Saif, congratulations for your excellent achievement in the CLAPS project in your unit. Do you have chlorhexidine 1% without alcohol or 0.5% without alcohol in your unit? And if not, do we safely can use chlorhexidine 2% for the extreme preterm baby less than 28 weeks? Thank you.
Thank you for the question. The recommendation not to be used, however, we don't have 1% or 0.5% chlorhexidine stick swab, so we are using it. And we ask the nurse to keep it for a few minutes and wipe it with normal saline, so not to do some irritation to the skin. We are using it for more than 15 years and we are doing great in this matter. We have no issue. But I agree with you, more than 10% or with alcohol should be used more than 4 weeks of age or more than 1 kilogram of weight. Thank you.
Thank you very much for our distinguished speaker and your attention and engagement. We will finish our session, first session. We'll take a break, coffee break for 10 minutes. We'll be back here at 35 or 40 maximum.
Thank you very much, all. We might extend it a little bit, 15 minutes, but inshallah we're on track today. Thank you very much.
Imagine being able to build an app with your name on it, just by thinking about it. Meet Base 44, a complete and watch it take shape. You can plan, customize, and expand in any
Hello?
We can start, please. Kindly come back to the venue. We will start with our second session. شيليها هو المتقاعد.
يعني هذه وش معناتها الكلمة تعلمت
بروفيسور متقاعد.
اميريتس؟
اي بس اذا
مرت من علي بالي يا رب بالي. زين اجل ما يحتاج اقولها.
اي لا تقولين يمكن ان الناس ما هو
اي بس بقول one of the key founders.
اي. We will start the session. Kindly you can join us again in the hall. We are starting the session. Please join us in the hall. أمري.
لما يقدم الشباب abstract حقتهم أنا ترفع evaluators يسألون أسئلة ولا move to the next؟
لا يسألون أسئلة أفضل لأنه يكتب on spot يعني. Starting the session, please join us. Hey. Hey. Okay, I think we can start, and once we start, people will realize maybe that we've already started. Very interesting session, the first one. It really focused on the theme of this conference, which is quality improvement and patient safety. Just to go along with the same theme, in this session, we'll be talking about what really shaped quality improvement in the past few years. We're going to talk about researches that really are considered landmark trials that shaped quality improvement. And I am happy to introduce our moderators for the next session. First of all, we have Dr. Sultan Yahya Asiri. He's a neonatologist in Khamis Mshet Maternity Children Hospital. He's in the Asir Health Cluster. Did the training back in 2018, and he's a consultant neonatologist there. Now, next we have Dr. Noura Salim. She's assistant professor of pediatrics at Princess Noura bin Abdulrahman University. She currently leads the NICU division at King Abdullah bin Abdulaziz University Hospital and the NRP program at Princess Noura Simulation Center. So for this session, we have Dr. Umar presenting, and then we'll have the abstract competition with all of our referees that we have, okay? So without further ado, please take over, Dr.
Thank you, Dr. Talal. Assalamu alaikum, sabah al-khair. Thank you for invitation to be part of this great conference. Our first speaker in this session will be Dr. Umar al-Khatib. Dr. Umar al-Khatib is a board-certified neonatologist who completed his pediatric training in Jordan and Canada. He pursued a neonatal perinatal medicine fellowship at the University of Manitoba, followed by targeted neonatal echocardiography training at the University of Toronto. He has served as a consultant neonatologist at Sick Kids Hospital, Toronto, and since 2015 at King Fahd Medical City in Riyadh. Dr. Al-Khatib is an examiner for the Saudi Council for Health Specialists, chairs the Neonatal Policies Committee at King Fahd Medical City, and has special interest in neonatal hemodynamics, HIE, PDA, and functional echocardiography. Dr. Umar, you have the floor.
Jazakallah khair, Dr. Sultan. It's a pleasure to be here. Thanks for the steering committee for inviting me. My talk, inshallah, in the next 20 minutes will be about landmark neonatal studies in the last 5 years. I have no competing interests to declare. The objectives is to review key neonatal RCTs between 2020 and 2025, emphasize the importance of evidence curation and dissemination. كلمة curation معناها انتقاء. زي ما if you are choosing fruit from the tree, you choose the best fruit. So curation, انتقاء. Dissemination means نشر. And then highlight the role of EB-NEO in translating research into bedside impact. And EB-NEO stands for evidence-based neonatology. As we know, that neonatal research output is massive, but not all studies change practice. Only a few trials have sufficient design rigor, relevance, and reproducibility. So to identify the signal within this noise is essential for safe evidence-based care. This is an approximate number of neonatal studies on PubMed per year. As you can see, in 2025, approximately 18,000 studies have mentioned the term neonate or infant or premature or NICU in them. It's a huge number. Who can cope with such a big number? I don't think anybody can cope with this number. So that's why there is EB-NEO, evidence-based neonatology. It's founded to curate and interpret neonatal evidence it's a global volunteer network, so it's completely non-for-profit. There is no profit, and there is no payments in it. It's just you are volunteering. The mission of eBNEO is to bridge research and clinical practice through concise, critical summaries, and the output of eBNEO is the impact article of the month. Every month since 2018, there is an impact article of the month in neonatology, and then among those impact article of the month, an impact article of the year is chosen every year, and that's present on the website. Haidar, if you can open the Microsoft Edge, please. Haidar. Just show you how to find the impact article of the month and how to find the impact article of the year in neonatology using any internet browser. So, yeah, so we have two websites open here, ebneo.org/vote. Try to record this website on your phone. Scroll down. So September 2025, August 25, so on, so on. Every single month. Scroll to the bottom of the page, please. And so on. And then open the other tab, which is Article of the Year. Scroll down. Again, so Article of the Year of the 2024, Article of the Year for 2023, 2022, 2021, and so on. Back to the presentation. So this is a website that chooses the best article in every single month in neonatology and posts it here and gets voting to decide what practitioners actually think is the best article. So there is a systematic monthly screening of more than 100 journals. It's graded by study design, sample size, and potential practice impact. There is editorial voting and independent peer discussion. And there is transparent posting with plain language summaries on social media like X or Facebook or Instagram or LinkedIn. eBNEO has accounts on all of them and posts. If you are a follower, you're gonna see those summaries. Okay, so what is a landmark study? A landmark study is a robust, reproducible evidence that changes practice or understanding. Think the TIP trial or the CAP trial or Felix et al. About hypothermia in preterm infants, or the TOBI trial. You know, those big RCTs that actually had impact on evidence. Those are landmark studies. There is a lot of fake and weak research, and so this is a lot of noise. And the task of eBNEO is to take this noise away and make you focus on the signal, which are good articles. So, as you are aware, there are lots of data in the literature. You need to do curation, so choose the best article. Oops, sorry. Curation and then dissemination, implementation, and then you'll have impact. So eBNEO makes this practice much easier and much shorter for you. There is no profit for it. There is no money this organization is taking for. It's just volunteer work. This is the social media team, which was selected a couple of years ago. I did not submit my photo, so they just put the eBNEO logo under my name. And as you can see, those are neonatologists from America, Australia, Canada, Europe, Saudi Arabia, and many other countries. Japan also. This is the mission and vision of eBNEO. I'm not going to waste time here. There is eBNEO's team led by Dr. Ravi Patel, professor of pediatrics in Emory University. Also on the EBNAU board is Harish Kirpalani and Barbara Schmidt. They are board members. This is a photo of us a few years ago when we met in the PS meeting. This our number of Twitter followings or X followers. And this is an example of the journals we scan. So all the top tier journals in the world, plus many other less famous journals. So we do a lot of work before we post and after we post about any article. And then we choose 3 or 4 articles published within the month for a public vote to choose the impact article of the month among them, ebnau.org/vote. And then among the impact article of the month winners every year, we choose the impact article of the year, again, ebnau.org/impact. Are there other neonatal blogs? Yes, Michael Narvi and Keith Barrington. Each of them has a famous neonatal blog, but they are doing things a little bit different than what EBNAU is doing. They have great discussion platforms. They are very good, but their job is not to publish every good article within the field of neonatology. Okay, so enough with this introduction, I guess. Now, I have collected 25 articles. I'm not gonna go in depth in all of them, just to show you the kind of evidence that has been curated over the last 5 years within the field of neonatology. This is just an example. I don't want you to go out from this lecture and say, I know this evidence. No, this is not my job. My job is to show you how to find the evidence, and how to discuss this evidence, how to vote for an article to be the impact article of the month or of the year. So starting with the top trial by Harish Kirpalani, published in New England Journal of Medicine, higher or lower hemoglobin transfusion thresholds for preterm infants. They used in the first week of life, 13 versus 11. In the second week, 12 versus 10. In the third week and beyond, 11 versus 8.5. And in their results, they showed that the higher hemoglobin threshold for red cell transfusion did not improve the survival without neurodevelopmental impairment at 22 to 26 months of age. This is a high impact study that will affect the decision to transfuse an infant in the NICU, which is a very common practice. And most of us will ask, what's the threshold? When should I transfuse? This is a study that answers this. The second example, initial laparotomy versus peritoneal drainage in extremely low birth weight infants with surgical neck or isolated intestinal perforation, multicenter RCT by Martin Blakely. In this study, they compared the efficiency of laparotomy versus Penrose drain. Again, this is a very common practice in the NICU. And they showed that the posterior probability that laparotomy was beneficial was 97% if the diagnosis is neck. So if you have neck and you have free air under the diaphragm, they are saying it's better to do laparotomy than inserting a Penrose drain. But if the diagnosis preoperatively is likely to be just perforation like SIP, then the probability of benefit with laparotomy is low. It's only 18%. The third study is the immediate KMC or kangaroo mother care, and this is published in the New England Journal of Medicine by the WHO group. And they showed that neonatal death mortality has been reduced in these countries where this study was done, which is Malawi, Bangladesh, and India, they found that mortality has been reduced with the KMC. This article has been actually voted the article of the year of 2021. RCT of fetal surgery for moderate left diaphragmatic hernia. As we know, there are many studies before this study that has asked the question, is doing surgery, fetal surgery, for a fetus who was diagnosed with CDH, is it useful or not? This study gives a final answer. And the answer is, it's actually not superior. So not every good study has to be positive, showing, yes, this is a good intervention and you should do this and that. No. If a study answers a question saying that it's not actually useful, then it is a good study because we didn't know this before. There is always a debate whether when should we do fetal surgery. طبعا, we are talking about advanced centers. So this study just puts an end to this debate, saying it's not superior. Fetal surgery is not superior. It actually has more complications with preterm delivery, NICU admissions, and so on. And when we talk about landmark studies, we should talk about Hammett et al., the Melody study, Nersivimab for prevention of RSV in healthy late preterm and term infants. As we know, the standard for RSV prevention is Synagis or Palavizumab. Now there is a new monoclonal antibody called Nersivimab, or Beyfortus. I think the trade name is Beyfortus. And by the way, same company. This is not a competing drug. The same company that made Palavizumab is the same company that made the Nersivimab. So they studied it on a very big group of infants for the prevention of RSV disease. The first study was in late preterm and term infants, اللي هم 35 أسبوع لحد الترم. And the second study in all preterm infants بدءا من 29 أسبوع وطالع. So two big RCTs, and both of them published in New England Journal of Medicine. And Nersivimab has been found to be effective and actually cheaper than Palavizumab. Very good efficacy. Very severe RSV-associated disease occurred in 0.1% in the Nersivimab group and in 0.5% in the standard care group. Those are thousands of infants. So 4,000 in each arm, so 8,000 infants, a huge RCT. The second, طبعا, we cannot talk about Nersivimab without mentioning the new vaccine for RSV that's given to the pregnant women to prevent RSV in their offspring. And it has been also published in the New England Journal of Medicine and is been found to be effective in preventing RSV disease. So again, I'm not here to show you the studies. I'm here to show you how to find those studies. Just log into ebneo.org. You don't need even to make an account. You don't need to make an account. Even just follow them on Facebook or X, ebneo. This is the name. Nasal high flow therapy during neonatal intubation by Hodgson et al. This is done in Australia. It's found to be actually very successful in reducing the intubation failure. This is a practice change study because by routine, we are intubating children while they are on room air or just like nearby oxygen. They have shown that giving high flow during the intubation has made the intubation more successful, has decreased complications, and is safe. Again, another New England Journal of Medicine. طبعا NEJM is #1 journal in the world. So if you see a neonatal study published in NEJM, then it's a good study, probably. Not that it's no mistakes in it, but it's a robust evidence. It's something that has a lot of hard work on it. Expectant management or early ibuprofen for patent ductus arteriosus by Hanschild, which showed that expectant management is actually not inferior to ibuprofen, and in many cases actually safer, where ibuprofen can cause renal impairment or necrotizing enterocolitis or SIP or bleeding tendency and so on. They have shown in this study where they recruited 273 infants that expectant management, which is basically restriction of the TFI, increasing the PEEP, allowing permissive hypercapnia, and just conservative management versus a medical treatment. They showed that ibuprofen is not superior, okay? Trial of erythropoietin for HIE. Erythropoietin, I know some of my colleagues here have used erythropoietin for babies with HIE because there are studies on it. But this study has answered this question saying that actually erythropoietin is not effective. So you better not use this medication because it does not improve the outcome. Very good study where they studied 500 infants. 500 infants, big RCT for EPO in HIE. The next one is about antenatal dexamethasone for late preterm infants, multicenter, double-blinded, placebo-controlled randomized trial in Lancet. And they showed, again, steroids for this group are not useful. They should not be used routinely. Again, this is one of the debatable spaces. If you give DEXA for a mom who is in labor at 35 weeks, does it improve outcomes? The study says no, it does not. And actually causes more hypoglycemia and causes problems in some babies. So it shouldn't be a routine use. RCT of surfactant therapy via LMA. And we know the new NRP is coming this year, inshallah, where LMA will be more utilized for resuscitation and also for surfactant administration. This study had found that using LMA is actually safe for surfactant administration. It's a big RCT, studied 51 versus 42 infants, and the efficacy of LMA was high, safety was acceptable, and then something to consider. If you are not able to intubate, if you are in a level 2 where the intubation skills are not so good, can I use LMA for administering surfactant? Yes, you can. Anup Kasaria, the king of cord milking and delayed cord clamping in the world, he's a neonatologist who works in California, published about umbilical cord milking versus delayed cord clamping in infants between 28 and 32 weeks. What do you think is the outcome of this study? Can anybody tell? No? The same. So milking is an acceptable alternative for delayed cord clamping in this particular gestational age group. Why? Because remember, this is a baby who has RDS that needs resuscitation. So nobody wants to wait with 30 to 60 seconds of delayed clamping. They want to bring the baby immediately to the resuscitator and start resuscitation, right? So he has found in this RCT that milking is an acceptable alternative to delayed clamping in this age group اللي هي 28 ل 32 أسبوع.
5 minutes دكتور عمر.
5 minutes قبل كده إن شاء الله. The next one is about higher versus lower nasal CPAP. It's called the ECLAT study, Again, multi-center randomized superiority trial by Kidman et al., an Australian group. And by the way, Australia is #1 in the world in the studies of high flow and nasal CPAP. Nobody is better than Australia in the CPAP studies. And they compared two groups of infants after extubation. So an extreme preterm baby that is extubated between 5 and 7 CPAP, and then the other group between 8 and 10. They have found in this study that the higher CPAP group, اللي هي من 8 ل 10, have actually done better than the other study. Unfortunately, many of us have what I call peebophobia. We are just concerned about high PEEP because pneumothorax and so on. The study is showing it is actually safe to extubate a baby to a CPAP of 10. And that will decrease the extubation failure, improve the outcomes, and so on. This study has been voted Article of the Year of 2022, I think. This is a follow-up of the Planet 2 trial. Is anybody aware of the Planet 2? So Planet 2, a big RCT from 2019 that compared higher versus lower thresholds for platelet transfusion. ايش الهاير 50,000 ايش اللور 25,000 to transfuse platelets if the platelet count is below this number. They have found in the early phase اللي هي Planet 2 that the lower threshold 25,000 they did better actually than the يعني if you transfuse only if the platelet count أقل من 25,000 in a preterm baby, the outcomes are better than if you transfuse if the threshold is 50,000. Now this is a follow-up at 2 years of age, and surprisingly, surprisingly, even at 2 years of age, the group of the 25,000 did better, had lower NDI, اللي هو neurodevelopmental impairment, had lower mortality. So that answered the question, what is the threshold I should transfuse babies on, platelet count? 25,000 is better than 50,000 and safer. Early human milk fortification in infants born extremely preterm, RCT. I'm not gonna highlight this study a lot, but it's safe to fortify milk when, like, even on protocol feeds. You don't need to be on full feeds to be fortified. Effect of early versus late inguinal hernia repair on serious adverse event rates in preterm infants. This is a very common question in the NICU. You have a baby born at 27 weeks, approaching discharge. Upon examination, you find an inguinal hernia. When should I operate this baby? Very common question, right? The study answers it. Actually, it's better to wait. It's okay to accept the inguinal hernia and not to rush for surgery before discharge. You can come back later for discharge. And the outcomes were very good because everybody thinks, no, it's hernia, it will strangulate, it will obstruct, and so on. It doesn't. Preterm pathophysiology is just different. So this study has answered this question. STAT trial, again, this is another surgical study, stoma versus anastomosis in the diagnosis of neck. So a baby who is undergoing laparotomy because of neck. If the surgeon sees necrotic segment, is it better to do ileostomy or is it better to just resect and re-anastomose and close the laparotomy? We did not know the answer for this until this study. The answer is resection re-anastomosis is better. Last study I will show is Fairchild, and Fairchild has been voted the article of the year of 2024. Fairchild is a neonatologist in Washington, and the study was about ventilator assistance before umbilical cord clamping in extreme preterm babies. And the study did not show that providing assisted ventilation before clamping reduces IVH or death. So again, this has been asked before. If I'm doing delayed cord clamping, should I provide bagging PBV during the clamping, or should I just wait? The study is showing that this bagging on PBV during the clamping is not useful. Again, it just ends the debate. 570 infants, big study, big RCT.
Dr. Omar, can you?
Yeah. Just a minute. طبعا فيليكس إيتال whole body hypothermia in preterm babies. This study اللي هي اللي فاتت هذه has actually changed the Saudi national protocol من 35 أسبوع إلى 36 أسبوع. See, this study had an impact. Thank you. This is ebneo.org.
Thank you, Dr. Omar, and sorry for this. But we will have only 2 questions for sake of time before we move to the next event.
Stimulate people to ask, not to say. شكرا دكتور عمر. We really enjoy it. دائما ممتعنا ما شاء الله عليك. لكن a question always will comes when we have contradicting results in these trials. You show us a lot of things that is conclusion, but sometimes you may have another studies or trial which shows conflicting result than this. So what will be the evidence better? We go to Cochrane will tell you we need further study to confirm it. So not a senior, as a junior neonatologist, I get confused when we have 2-3 trial contradicting results in each other. Thank you.
Thank you, Dr. Abdurrahman.
I'm still junior.
So that's when the critical appraisal is needed. So critical appraisal بالعربي التقييم النقدي لأي دراسة جديدة. We need to do it in details, right? Not just say this is NEJM publication or this is JAMA publication and آمنت بالله وخلاص وراح أنفذها عمياني. لا, you need to critically appraise. You need to make sure that the study population is similar to your population. The study resources is similar to your resources. لأنه sometimes خاصة في موضوع ال PDA مثلا. Okay, PDA has not been found to يعني treatment of PDA has not been found to be useful. However, we have higher than average rate of pulmonary hemorrhage because many hospitals suffer from decreased quality of nursing care, like maintaining the CPAP mask on face. Can I apply results تبعت ال Benedictus trial أو تبعت ال ibuprofen expectant management? Can I apply it 100% here? No, I can't, because the quality of nursing care is different. If I am having more than average rate of pulmonary hemorrhage, probably I need to close more PDAs to prevent this pulmonary hemorrhage. Okay, so the applicability part is very important. It's not just I have the evidence, you shouldn't do this or that. You need to make sure that the applicability of the study in your own setting. Critically appraised, and among the studies I have shown here, I'm not aware of any big RCTs that's actually contradicting them. There are smaller prospective observation studies that are maybe contradicting, but like large RCTs, like for the nirsevimab, there is no study that says nirsevimab is not effective. No study, okay? And inguinal hernia, there is no big RCT. This is the only big RCT about inguinal hernia repair, and so on. Yeah. Yes, exactly. Think globally, act locally.
شكرا دكتور عمر. I think it's a comment and it's a question for everyone here, especially the leaders. When are we going to be on the map as Saudi neonatal network? We're not on the map. We're still presenting others. We're on the map, football-wise or soccer-wise. Well, everyone knows that we have such and such, but no one knows our population. No one. When are we gonna have our multi-center collaboration? When are we gonna publish our own? دكتور عبد الحكيم قال احنا عندنا low rate of BBD. من زمان احنا عندنا low rate of BBD, but nobody knows. We're not collaborating to publish. I'm saying that now. I always have these thoughts, but I never was encouraged to say that. But I'm saying that now to inform everyone, and I inform Dr. Jubara. In the university, inshallah, we're working on a database that is going to be international for international people to see. But as a center, it will never be on the map. We need to be multi-center. And it's only the Saudi Neonatal Society we can say that. Where can we say that? So it's for everyone to think about. We're happy to collaborate.
الله يجزيك الخير يا دكتورة هايدي.
Thank you. Now I will give the mic to Dr. Nora for the next event.
يعطيك العافية دكتور. Assalamu alaikum everybody. We'll move to the second session for second part of our session today. It's nice to be here between the most expert and our young future neonatologist. So in this session we'll be presenting the abstract competition. First I would like to invite our judges, starting with Prof. Saleh Al-Alayan. Everybody knows Prof. Saleh. He's one of the key founders of the Saudi Neonatal Society and a well-known figure in new research, and participated in a lot of research in the kingdom and in developing guidelines in Saudi Arabia. The second judge is Prof. Khalid Al-Faleh, professor at King Saud University, currently in Sulaiman Habib Group, well-known researcher and in Saudi Arabia with multiple publications. And our third judge, Dr. Muhammad Al-Hindi, head of section of intensive care unit, National Guard in Jeddah. So kindly judges, you're welcome to join us in the podium. So we'll start our first abstract presentation. We have 5 abstracts today. So the first, actually each abstract will have a presentation 5 minutes, followed with 2 minutes of questions by the judges if they have any question for the presenters. So we'll start with the presentation of Dr. Abdullah Safar Al-Ghamdi. His presentation abstract will be about impact of free feeding syndrome on the short-term clinical outcomes of very premature infant. تفضل دكتور, you have 5 minutes to present your abstract.
Good morning. First, I would like to thank the Saudi Neonatal Society to give me this opportunity to present this case. It was done at King Saud Medical City during my fellowship. So today, inshallah, we'll talk about impact of refeeding syndrome and short-term clinical outcome of premature infant. Refeeding syndrome, it was electrolyte disturbance, lead to fluid shifting when the nutrition rapidly starting after prolonged MBO. It's triggered by insulin surge, lead to electrolyte move intracellular, and lead to hypophosphatemia and hypokalemia. That can lead to complications like cardiac, respiratory, hematology, and neurological complications. As we know, the preterm infant lack the 3rd trimester nutrition creation lead to low reserve at birth, small gestational age, and IUGR further hitting deficiency risk. As we know, the other recommendation for protein intake, it was 3.5 to 4.5 grams per kg per day, but excess of that can be lead to acidosis, hyperammonemia, and precipitate breastfeeding syndrome. Refeeding syndrome rate in the very term infant very widely reported at 20% in profile trial and up to 90% at high risk for small gestational age, IUGR, or early aggressive parenteral nutrition. The variation likely reflect different definition and population, but the remaining syndrome common and clinically important problem worldwide. So there is no clear definition for the refeeding syndrome yet established, but after review, the literature review, we use that definition: hypercalcemia more than 2.8 millimole per liter, hypophosphatemia between 1.1 to 1.6, and severe hypophosphatemia less than 1 millimole per liter. So our aim of study to examine the short-term clinical outcome of refeeding syndrome in the preterm infant less than or equal 32 weeks of gestational. And it was retrospective review study done at King Saud Medical City at NICU level 3. The data collected from January 2015 to June 2024 with annual admission in the King Saud Medical City is 1,100 per year. It was approved by ethical committees and informed consent waived. So we include the preterm less than 32 week with the weight less than or equal 1.5 kilogram, born at King Saud Medical City, and starting TPN, parental nutrition plus lipid within 24 hours. We exclude congenital malformation, patient did not receive parental nutrition, outborn or transferred to another hospital, either missing data or died within 7 days of life. So the primary outcome study, it was short-term clinical outcome for refeeding syndrome preterm infant born at less than 32 weeks of gestational as IVH mortality or long duration of TPN. So regarding statistical analysis, infant maternal data summarized as median frequency, t-test for normal data, Mann-Whitney for non-normal, Fisher for categorical. Also, we use the univariate relative risk to use link refeeding syndrome with neonatal outcome, and the p-value less than 0.05 it was considered significant. So we include 2,465 preterm. It was initial that meet inclusion criteria. We exclude 1,705 due to our excluding criteria. The remaining 760, and the baby we have refeeding syndrome is 289, and without refeeding syndrome 471. So in this diagram, we found that the refeeding syndrome patient has low gestational age, low birth weight, and low Apgar score with statistical significant with the p-value. And moreover, the male sex, it was high risk for the refeeding syndrome than the female. Also, refeeding syndromes found developed for patients that require more surfactant, more dose of surfactant, and average the peritoneal lipid, protein, and phosphorus, and total duration, it was associated also with refeeding syndrome. In this univariate analysis, we found significant associated refeeding syndrome with neonatal morbidity and mortality. So we found statistical significant for composite outcome, mortality, IVH, severe IVH, late onset sepsis, and bronchopulmonary dysplasia with statistical significance less than 0.01 respectively. And also there is no association between duration of invasive ventilation and length of stay in the hospital. Here in multivariate regression analysis, we find significant associated refeeding syndrome with composite outcome IVH and IVH with adjusted relative risk factor 1.7, 1.59 respectively. Moreover, the hazard ratio for death infant with refeeding syndrome increased by 1.74-fold. So in our discussion here is a patient less than 32 weeks developed refeeding syndrome in the first week, has associated with high IVH, hospital mortality, BBD, and late onset sepsis. No significant difference were found for duration of mechanical ventilation between refeeding syndrome and non-refeeding syndrome group. The key risk factor, it was male sex, IVH, and low sodium phosphate intake in first week. And other reports, they found the IUGR and the small gestational age and high amino acid strategies. Consist with profile study, the refeeding syndrome triple mortality and severe hypophosphatemia, 5-fold higher IVH risk. And in our cohort, the mortality rate was 42% for refeeding syndrome patients compared to 32 in the profile. And there is no significant difference between non-refeeding syndrome mortality between two studies. And also the refeeding syndrome with IVH is high link is echoed by another different studies. Some study found there is no difference for mortality and IVH due to small sampling, low IVH incidence or variable refeeding syndrome deficiency definition. And late onset sepsis, most study, including the profile, show no difference, but there is another study like Malto, they found the higher late onset sepsis with very low birth weight. So in conclusion, preterm infant at less than or equal 32 weeks, the patient developed refeeding syndrome within first week of life. It was high risk of IVH, mortality, and long duration of TBN. And our recommendation to be standardized neonatal refeeding syndrome definition across in ICU, multi-center prospective trial to optimize parenteral nutrition balance, and implement structure lab monitoring via multidisciplinary team. Thank you.
Thank you, Dr. يعطيك العافية. Any questions from the judges or the audience? Doctora, can you give her the mic there?
Nicely done. Allah, mashallah, Allah يبارك لكم. بس what did you, because you had a table of regression, so what did you adjust for? يعني عشان refeeding, as you said, it's not easy to define. So what did you adjust for? That's the first question. Number two, as you mentioned, hypophosphatemia is a big thing in this refeeding thing. So where is phosphate here? Like the intake, the levels, the difference between the two groups, where is it there? Thank you. If you want me to repeat, I can repeat.
Yeah, please.
Repeat?
Yeah.
طيب. First, in your regression table, you said adjusted odds or risk. So what did you adjust for?
So we adjust that, we try to apply that IVH bundle for that patient, and also monitoring the TBN with the lab to avoid this complication.
I don't think you got my question. We can discuss it after. The other question was phosphate monitoring, or in terms of intake or levels, part of this study?
Yeah, it was monitoring by the lab monitoring.
Sure, but was there a difference between the two groups?
Yeah, that patient has low, because this study came from the previous study, the incidence of the refeeding syndrome in our center.
So what I mean was the hypophosphatemia more in the refeeding syndrome?
Yeah, it was more in that patient with refeeding syndrome.
Yeah, because many relate what's happening to the hypophosphatemia per se and the amount of protein. I saw that you mentioned the amount of protein, but well done, thank you.
Thank you very much, Doctora. Thank you very much, Dr. Abdullah. We'll move on to the next presenter, Dr. Mohammed Ahmed Amr Salaut will present a ROX index as an indicator of non-invasive ventilation failure in neonates. تفضل دكتور.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the organizing committee for giving me this chance to present my research in King Faisal Specialist Hospital and Research Center. My research is about ROX index as indicator of non-invasive ventilation failure in units. A predominant reason for admission to an ICU is respiratory distress that may need respiratory support ranging from non-invasive ventilation to invasive ventilation. A significant cohort of patients may experience deteriorating respiratory function despite initial NIV support. To predict NIV failure, medical professionals rely on a blend of clinical judgment, ventilator setting, blood gas analysis, and vital sign monitoring. No widely adopted objective tool tailored to neonates to anticipate non-invasive support failure. ROX index is defined as the ratio between SpA2 divided by FI2 to respiratory rate. The ROX index has been used as potential predictor of NIV outcomes in adult and pediatric cohorts. There is no published data in neonatal population until present. Our objective of the study was to evaluate the diagnostic accuracy of the ROX index measured at 72 hours of age after initiation of CPAP or high flow nasal cannula or post-extubation to non-invasive support for predicting weaning success and to identify clinical factors associated with weaning failure. For the method of the study, it was a retrospective cohort study that includes all neonates admitted to NICU at King Faisal Specialist Hospital and Research Center in Riyadh from January 21 to end of December 22. Data were collected from the Medical Record Integrated Information System, short ISIS, and NICU database. The ROX index was collected from the ISIS or calculated manually from the displayed vital signs and the FiO2. We included all neonates who required NIV as initial mode of respiratory support in the first 72 hours, or all neonates were initially intubated, then extubated to NIV within the first 72 hours of life. We excluded all neonates with major congenital anomaly, major brain insult, major airway malformation, or patients who required elective intubation for short-term procedure. Primary outcome of our study was treatment failure within 72 hours after starting NIV. The treatment failure defined as when the baby reached receiving maximal support NIV, if high flow nasal cannula of 5 liters, or CPAP 7 cm water, plus at least one of the following: sustained increase in the FiO2 more than 50% in 1 hour to reach the target saturation 91 to 95, or any patient required urgent intubation and mechanical ventilation, or any patient reached escalation to non-invasive high frequency, or any baby who failed weaning of NIV at 72 hours, 2 hours of age. For the statistical analysis, we analyzed the data using Stata version 18. Continuous variables were summarized as medians with interquartile ranges, and categorical data are as counts and percentages. Group comparison used Mann-Whitney U-test and chi-square test. Diagnostic performance of the ROX index was assessed by ROC analysis. The optimal cutoff was determined by Uden's index. Multivariable regression analysis identified factors independently associated with weaning failure, with results reported as odds and 95% confidence interval. For our results, we included 210 patients. Out of them, 133 patients were male and 77 were female. The gestational age, the median was 34, and the interquartile range was 32 to 35. The birth weight was 2100 as median, and the interquartile range 1660 to 2580. Patient who required mechanical ventilation was 39, and the duration of mechanical ventilation median was 72 hours. And we used surfactant in 89 patients, and 3 patients have air leak syndrome at the end of the study, and 2 patients required home oxygen, and the median length of stay was 13 days from 6 to 24 as interquartile range. The maternal characteristics: 141 patients received antenatal steroid, 9 patients were GPS positive, 22 patients delivered by SVD, 188 patients delivered by cesarean section, and 127 patients were multiple pregnancy, and 83 were singleton. Outcome of our study: out of the 210 patients, 166 patients succeeded the weaning from the NIV in the first 72 hours. The ROX index for this success group, the median was 9.7, and the interquartile range was 8.2 to 11.7. And 44 patients, was 21% of the total number, failed the weaning from the NIV in the first 72 hours, with median ROX index of 4.7 and the interquartile range 3.6 to 6.2. The overall ROX was skewed to the success group, so the median was 8.9 with the interquartile range 6.8 to 11.
Have 1 minute.
Factor associated with weaning failure, I think I have 10 minutes. I asked Dr. Talal to give me 10 minutes.
Okay, carry on.
Sorry.
Carry on.
That's okay. So factor associated with weaning failure, we did the univariable and multivariable analysis. We included all the data, including the outcome in the multivariable analysis. Out of them, the patient who required mechanical ventilation and the overall ROX index were statistically significant with p-value less than 0.05. In adjusted models, prior mechanical ventilation remained independently associated with failure with OR of 7.6, 95 confidence interval 1.4 to 38. Higher ROX index at 72 hours were independently associated with winning success. OR per unit increased 0.35 with 95th confidence interval 0.2 to 0.5. This figure is showing the ROC analysis for our study, for the ROCs itself. So it demonstrates excellent discrimination with area under the curve 0.947. The diagnostic performance of the ROXY index, a threshold of 7.1 at 72 hours. This is by the Udens analysis, yielded sensitivity 88 and specificity 91%, with positive likelihood ratio of 9.7, negative likelihood ratio of 0.1, positive predictive value 97.3, and negative predictive value of 66.7. These parameters indicate that neonates who has ROXY index more than 7.1 are substantially more likely to be successfully weaned from CPAP or high flow nasal cannula, while lower values signal increased risk of early failure.
30 seconds.
ROXY index was initially developed in adults and with hypoxic respiratory failure, and more recently in pediatric population. Our study will add value by providing neonatal specific evidence. The clinical utility of the ROXY index in this setting appears twofold. First, the high role of performance at 7.1. Second, because the negative predictive value was more modest, low ROXY values showed promptly assessment rather than escalation. Significance of the study, it will add value by providing neonatal specific evidence for ROXY index, pre-specified time 72 hours, objective and clinical relevant failure criteria, and comprehensive capture of covariates from the electronic records. Our records include both initial non-invasive support and post-extubation cases, which increase generalizability, limitation, single center, retrospective, potential founders, co-founders, duration of the follow-up, and distribution skewed to the late preterm. To conclude our study, the ROXY index measured at 72 hours is a promising predictor of readiness to wean neonatal patients from CPAP or high flow nasal cannula. A cutoff of 7.1 provides a clinical actionable balance of sensitivity and specificity, and may help standardized decision making, reducing both premature weaning and unnecessary prolongation of support. Prospective validation across diverse NICU setting is warranted. And this is my references. Thank you.
Thank you very much, Doctor. It's 7 minutes for presentation, 3 minutes for discussion. We even expanded because of the canceled last presentation. That's okay. No problem. Allah yawafqik, inshallah. No problem. So
we have to be fair with everybody. Even if you requested before the meeting, we have to be fair with all the competitors to give them enough time for their presentation. We'll stop at this stage. We'll allow only one question from the audience, and then we'll move on to the next one.
any question? تفضل دكتور.
This is a question. This is a good question. Actually, in the limitation of the study, the follow-up should be prolonged. 72 hours, by definition, it was the failure of both patients who are extubated. They define the extubation failure that the babies who failed extubation within 72 hours. So they reintubate within 72 hours. But actually, it can be prolonged because there is babies with BBD can be extubated later, and then it needs more and more collection of data after that. Thank you so much.
Thank you, Dr. Mohammed. Thank you very much. We'll move into the next presenter, Dr. Abdul Ilah al-Shehri. He will present his abstract about pathogen profiles and antimicrobial resistance patterns of neonatal sepsis in Gulf cooperation. A systemic review. تفضل دكتور عبد الإله.
السلام عليكم حياكم الله جميعا. My name is عبد الإله بن فايز الشهري, a medical student from Imam College. First of all, I would like to thanking for organizing committee and also for giving the chance to share our systemic review, which is titled Pathogen Profile and Antimicrobial Resistant Patterns of Neonatal Sepsis in the Gulf Cooperation Council, which is a systemic review. So neonatal sepsis is still a major cause of death among newborns. It affects thousands of infants every year, especially in developing countries. We divide it into two types: early onset, which is usually come from the mother. On the other hand, we have late onset, which mostly hospitalized acquire. Even though Gulf countries has or have advanced in ICU, we still have we still don't have enough clear data about the common pathogen or how resistant they become to antibiotics. That's exactly why we do this study. This is our objective. So the methodology behind our research involves several key steps. In the beginning, it's followed by the BERISMA guideline 2020. The number of studies include around 54, representing 5,177 neonatal sepsis cases, which is a huge number. We defined neonate as less than or equal 28 days. Our research covered all 6 countries, which is Saudi Arabia, Qatar, Kuwait, Bahrain, Emirates. Across 3 major databases: Web of Science, PubMed, also Scoop, between 1985 to 2025. So it's a long systemic review. We include studies that reported as confirmed neonatal sepsis with identified pathogen, employed only observational study, which is a cross-sectional study and retrospective, or even cohorts design. We exclude any case report or reviews or conference abstracts. Studies with laboratory confirmation were excluded without laboratory confirmation. Finally, we conduct descriptive synthesis. We couldn't make meta-analysis because we have high heterogeneity. So this BERISMA flow chart show how we selected the studies for our review, starting from 949 studies. Then we choose only 54, which is article includes. So moving to the results section, this is where things get interesting. Across these 6 Gulf countries, we analyze data from, again, 5,177 neonatal sepsis for, as you can see in the figures, gram-positive bacteria made up almost half of all cases. Moving to gram-negative, which is a 44.8, and small portion, around 6.9, is a fungal infection. When we look more closely at individual pathogen, the leading ones were coagulase negative staphylococci, followed by Klebsiella, Staphylococcus aureus, then E. coli. Now let's take an overview about resistant they have become, starting with the dominant gram-positive isolated, which is a coagulase negative staphylococci. Showed very high resistance to several first-line antibiotics, especially ampicillin, oxycillin, and erythromycin. In contrast, coagulase negative staphylococci stayed highly sensitive to vancomycin. Now let's move to the gram-negative side, focus on Klebsiella, which were the most frequent gram-negative pathogen across our data. Klebsiella show high resistance to several first-line antibiotics, including amoxicillin and cefotaxime. This show that may of the usual first treatment line in ICU may not work anymore against the bacteria. So moving to discussion and clinical implication. First, the changing trends. We notice that coagulase negative staphylococci have new replaced group B streptococcus as the main gram-positive bacteria. On the other hand, Klebsiella has become the leading gram-negative. Second, antibiotics resistant. We found that high resistant to common first-line drugs like ampicillin and oxycillin. So the usual empiric treatment are not working as well as before.
1 minute.
Okay. So to conclude, neonatal sepsis is still a major challenge across the Gulf region or even worldwide. The main message is our empiric antibiotics protocols need to update and develop. In short, there is a medical progress, but at the same time, the bacteria is getting stronger with the time. So before I end, I want to thank my research group for great effort. That brings us to the end of the presentation. Thank you. If there are any questions.
One question for Dr. Abdulillah, if anyone have a question. If not,
Assalamu alaikum. Very good presentation. Do you have a segregation analysis whether you did ever early onset versus late onset sepsis?
Sorry, again?
Did you do any segregation between the early onset and the very late onset?
Okay, thank you for this interesting point. We made it as a limitation in our study. Also, there is another limitation which is we generalize the data for all 6 countries. So it will be, inshallah, in a future workshop. Any question?
Okay, thank you very much, Dr. Abdullah. We'll move on to our next speaker, Dr. Dalal Ashmawi. She will present her abstract about risk factors associated with loss of follow-up for newborns with failed hearing screening. Experience from the Saudi Tertiary Care Center. Dr. Dalal, تفضلي.
Okay, good morning, everybody. I'm Dalal Ashmawi, pediatric resident in Prince Sultan Military Medical City in Riyadh. I'm excited today to share our experience and risk factors associated with loss to follow-up for newborns who failed the hearing test at our center. Okay, congenital hearing loss is one of the most common problems in newborns. We all know that early detection can have a great impact on the outcome. It has an impact on the brain development, speech development, and language development. In Saudi, we have made great progress. A screening program that was started in 2016 now has coverage more than 90% of the hospitals. So in 90% of the hospitals, all newborns are screened for any hearing problems. At our hospitals, our nurses are well trained to do the hearing test using the automated auditory brainstem response device with high accuracy. Usually the test will be done when the baby is at the age of 24 hours of life. We try and follow the 1-3-6 international rule, which says to screen a baby at the age of 1 month, establish a diagnosis, if any, at the age of 3 months, and start treatment by the age of 6 months. But we found a problem that was weakening this program. Many families, they're not returning for the follow-up, so a proper diagnosis was not being established, nor a treatment or an intervention was started. Even if we have the resources, the treatment was not given to the baby. This actually does not only weaken the pathway, it disables it. There is no point of doing a screen if we're not able to give the proper treatment. So our research aimed to investigate into that. Why aren't parents attending the follow-up? What is the reason? Is it common that they're not attending, or it's a small percent? So our study aims was to assess how many infants were lost to follow-up, how many parents they're skipping the appointment. And if there is a good number of parents who are skipping the appointment, why they're skipping the appointment, and based on that, try and find a solution that are practical and simple to fix the problem. So what we did, we reviewed all infants that were born between July 2023 till June 2024. During that period, a number of 8,000 babies, more than 8,000 babies were born in our hospital. They were screened for a hearing test using the same device I mentioned. Out of these 8,000 babies, 366 failed the test. So those babies, the 366 babies who failed the hearing test, were supposedly planned for a later follow-up appointment. So we looked into how many out of these 366 babies attended the appointment. What we found that out of the 366 babies, the number of parents who attended the appointment was 62 only. That's less than 17%. So we had more than 300 parents that skipped their appointments even though their baby failed the screening hearing test. So what we did, our team called the 304 parents and asked them one by one what were the reasons that they skipped their appointment. What we found is that the number one reason that covered more than half of the cases was parental unawareness or misperception. Most of the parents knew about the negative results, but they did not know that a follow-up was needed. Other parents knew about the negative result, knew about the follow-up, but they did not get the message that it was a very important follow-up to attend. 17% said that they forgot or had other priorities. 15% has actual logistical barriers. We can consider these results as good news, because if more than half of the problem is awareness or communication, that's something we can work on, rather than an actual logistical issue that is relatively harder to tackle. At our center, the loss to follow-up was 83%. That's very high. And we found that babies that were from the postnatal ward were more likely to miss the appointment in comparison to babies that are from NICU. NICU parents were found to be more careful with the appointments and understood the importance of follow-up. But parents of healthy term babies were most likely to miss the follow-up. So the message here, what we learned, is that every parent needs proper counseling, not only parents of babies who had sick or premature baby. Every parent wants the best for their baby, and it is our job as healthcare providers to help them and guide them and support them in giving that care for their babies. We need to guide them to make sure that no child is left behind. So, being a parent is already hard of its own. Imagine having extra appointments that you have to attend. So we really need to simplify the system and help and make the system more supportive for these parents. What we can do, first start with strengthening parental counseling before discharge. We as healthcare providers understand the follow-up understand the importance of follow-up, but we're not delivering that idea to the families. We need to make sure that they understand why the follow-up is important and what are the consequences on their child's health if they miss the appointment. Also, we can link the follow-up to routine vaccination visits that the family will already go to that will lessen their visits to the hospital. Also, we can help them remember the appointment by calls or SMS or make the booking easier. Regarding our study, it's the largest to be done in Saudi about this topic. It's the first of its kind, and even though it was done in one hospital, it included families from all income levels, both civilian and military.
1 minute left.
And even some babies came from outside of Riyadh, so the data represented a wide group. Also, the 304 parents that missed the follow-up were individually contacted by our team. We didn't just call, we listened, answered their questions, addressed their fears. What started as a simple phone call as a data collection turned out into a small awareness campaign that helped those parents deliver the best care for their children at the right time. Yet, this is only single study, a single center study only, so the data might not represent the whole country. Also, we relied on parental memories during the phone calls, so that can affect accuracy. At the end, our Hearing Screen national program is excellent, has high coverage, but with a very high loss to follow-up rate, which defeats the purpose of the screening program. And the main reason is parental awareness. And that responsibility relies on us as healthcare providers to deliver the right message to the family. At the end, I want to thank our nurses. Without them, this program wouldn't have been possible. I want to thank my co-authors and the Saudi Neonatology Society. Thank you all for listening.
Question? تفضل دكتور.
Yeah, actually, of the babies that we screened. Okay.
Thank you.
It's already closed.
Haider, can you show the slide, please? Because it's not 2%, it's higher than that. I'll show you why.
Okay.
More.
I think I know which one.
Yes, here.
This one.
Okay,
Yeah.
so 8 infants confirmed with permanent hearing loss, تمام? Many 62. 8 out of 62. That's like 13%.
That's part of the idea that alarmingly 8 infants were found to have to be confirmed with permanent hearing loss.
Yes, yes.
But we missed a lot of cases.
مظبوط. فأنت الدينومينيتور تبعك مش ال 300، الدينومينيتور 62، لأن 62 فقط هم رجعوا على العيادة for hearing assessment.
Yes.
منهم 8 طلع معهم، فبيطلع البيرمننت هيرنج لوس 13% من اللي فيلد أول تيست. This is يعني معلومة مهمة جدا إنه it's not 2%, it's 13%.
No, but we measure it from the all population, the 8,000.
No,
لا. From 1.3, from 1,000 screened babies.
8%, 2.1% out of what? 8%.
Out of the 8,000 screened babies.
لا، ما هو 8 على 8,000 ما بيطلعش 2%. 8 على 304 بيطلع 2%. تمام. لكن it's not should not be 8 over 304. It's 8 over 62.
Okay.
فبيطلع الانسنس لو الطفل failed الهيرنج assessment at birth، تمام؟
Yes.
احتمالية انه يطلع فعلا عنده permanent hearing loss 13%, not 2%. So that's a big number, يعني just to be aware of.
Thank you.
Thank you very much. That was our last presentation. The last one will not be able to present. They are not here. Back to you, Dr. Talal. Thank you.
Thank you very much for all of the presenters, and a lot of thanks for the moderators and also the judges. Thank you for taking notes and giving us the final score. So we'll release the name of the winners by the last day. We have the abstract competition, the poster competition, and also the winners. We'll announce them there. Winners for all of them will receive free registration for the next conference, along with the first place. They'll also get 3,000 riyals along with accommodation, 2,000 riyals for a second place, and the 1,000 riyals. And now we have concluded this scientific session. Thank you so much for all of the judges and the moderators again. And now we will move to our sponsored talk. The platinum sponsor, the company is EasyWell. I would like to invite, and sorry for butchering the name if I
may say. David Azunu, he's a research and development manager in infant nutrition at St. Mary. He'll be talking about advanced technology in infant nutrition. Is he around? Okay, so it seems that David is outside. That's him. He's here. Okay, I think there might be some delay, so we'll probably keep it after lunch. We'll have a sponsor talk. Yeah. And we'll hopefully see all of the judges in the gala dinner along with the speakers. Thank you very much.
The lunch break and the prayer, there is a prayer place downstairs in the basement, so you can go and pray. And also for the lunch, the speaker and the moderator, their lunch will be in Al Bustan restaurant, Al Bustan. So you proceed to Al Bustan. Or the delegate will have the lunch here near to this hall. We'll gather again to hear this speech from the main sponsor 20 minutes before 1:30. So the program will start again 1:30. And 20 minutes before that, the main sponsor, they have a presentation and they have a competition. They have some prizes for you. So you should come back. So you will win. Maybe, a ticket to somewhere else or whatever. But anyway, so you are welcome all. Enjoy your lunch and thank you. Yeah.
Check sound check.
Imagine bringing your side project to life.
Check, sound check, 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 check. check, sound check.
السلام عليكم. مساء الخير. I know it's maybe many people are not here yet, but because of the time and our schedule should not be that late, we'll give 20 minutes for our main sponsor, the platinum sponsor. They are having a small, presentation for you, and I wish it will not last more than 15 minutes. So are they here, the Aizobel? Aizilak, where you are? Do I see you? Yalla, come. Please, go ahead. People, just after lunch, post-brandle, you need to really make them awake. I think they have some surprises for you to keep you awake and reward you because you come early, after lunch. Go ahead, Dil. Thank you very much. You are welcome.
Hello, I'm very glad to be with you today. And it's an honor to present you some innovations in technologies in infant nutrition. Okay, I take part of cooperative Isigny Sainte-Mère that you see here in Normandy, in France. Donc a piece of history to show you a bit our big experience on 66 years approximately. Donc we began the creation of a cooperative at the beginning of the 20th century, as you can see. And the first baby milk powder production in Normandy and France was done at Isigny in 1959. After we extended some capacities with new drying towers. I will show you right after the process, manufacturing process. And we added also a laboratory, a powder testing laboratory, to be able to test as much as we can internally all our finished products. Look, as you know, we are in the middle of a magnificent territory, Normandy. Donc, a bit different than Saudi. Donc, it's a big giant swamp. As you can see, we are in the middle of a giant swamp between land and sea, with that brings you exceptionally rich grass growth and helps the cows to have this perfect nutrition. Donc our gold at Isigny is not oil, as here, or something else. It's our milk. Donc it's collected around the cooperative, around the factory, approximately maximum 50 kilometers around the factory. Our farmers are our boss, in fact, because we are a cooperative, we are a dairy cooperative, not a private group. And we produce really locally, and we use fresh milk, because we'll collect every 48 hours on each farm, and it arrives fresh at the cooperative. Talk about some technologies. Wanted to present you something that you don't know very well as neonatologists or pediatricians. Three main advanced technologies in infant nutrition. Our first, general consideration about full wet blending process of manufacturing. And after two very interesting and sensitive ingredients, DHA and iron, that we protect through encapsulation. First, we collect the milk, you understood that, and we bring to a cooperative. We will, of course, analyze and pasteurize to make it fully clean in liquid phase. We will after mix lots of ingredients with the milk, depending on the formula. Now we have over 1,500 different possibilities of ingredients. We'll pasteurize again this mix, liquid mix, and homogenize to have a perfect quality. And we will follow at each step with auto controls the composition, the criteria, the physicochemistry, physicochemical criteria, and others, and sensory also. We'll concentrate on mixed concentration to be able to remove some water before going to the big drying towers. And after we will proceed on a big drying tower that you see on the screen to evaporate the remaining water and to produce powder. Through all of that steps, we'll continue to analyze, to check the conformity of everything, composition, density, for example, scoop weights, etc. And we will finally go into packing steps when we are ready, before getting to palletization. And the release will be done on all the traceability elements, results that you have along the process, and also some auto controls, as I said, and critical control points that you know. And after, also on the release on the laboratory analysis that we have internally and sometimes externally, to release the batch on all of its results. Donc the main thing to retain on this drawing is we are working as much as we can on the full wet blending process in liquid phase to have something very homogeneous, to guarantee the food safety and to respect and to protect the nutritional part, nutritional quality. And as you see also, we are preserving the freshness of the milk, because between the collection and the arrival at the cooperative of the milk and the finished products, we have maximum 72 hours, which is quite very short time, and make a good preservation on the quality of milk. Donc, some pictures, quickly, wanted to pass it through because it's quite interesting on the process that you don't see every day. Look, you see many different things, different parts, different equipments. For example, pasteurizer on the left, on the bottom. And you see lots of controls on quality. We'll come back on it, on environment, on equipment. As you can imagine, it's like in your surgical operations room. We use approximately the same rules to ensure perfect food safety for babies, including premature babies, for example. And lots of things to permit to go, to be reactive and to go quickly from the milk to the finished products. For example, the silos of powders that you are seeing on one of the pictures. And as I told you, all the auto controls, you see a bit of powders testing by composition at one part to be sure that at each step we have a perfect quality. We can add something else because we are working in a liquid phase, 100%, and we can add some additional options to protect sensitive ingredients, as I told you, particularly DHA or iron, for example. And for DHA, you know that DHA is one of the main polyunsaturated fatty acids with long chain found in breast milk. It's not present in cow's milk, and the amount of DHA is very different from one woman to another, depending on diet, nutritional status, and other factors. And in breast milk, the average concentration of DHA seems to be close to 0.32% of total fatty acids, as we saw in this study in 2019. And in human body, you know that it's accumulating in the brain, in the retina, during pregnancy and early childhood. Your colleague Colette Sco from ETSGAN told us that in 2008, as we knew, as we imagined before. And it takes part more specifically on the, we can say, the brain for 40%, and on the retina tissues for 60%. However, the rate of conversion from alpha-linoleic acid, that you know very well, to DHA in humans is low, less than 1%, as we saw in some reports, for example, from EFSA in 2006. Donc, DHA synthesis is limited in infants, donc therefore it must be obtained from infant nutrition. And also, as you can imagine, it's the longest polyunsaturated fatty acid, DHA, donc very sensitive to oxidation. Donc it can bring strong fishy smell and flavor. You had this experience by the past, I imagine. And it can be nutritionally denaturated, which is not so good for all of us. Donc where technology can help to protect these very sensitive fatty acids. Donc a bit of process. Donc we will mix all the lipids and the other ingredients, protective ingredients I will show you in the liquid phase to make an emulsion in the first hopper and the first tank. And after we will spray dry, as we do on MSD, multi-stage dryer for finished products. We'll spray this liquid inside a very dry and hot air to be able to evaporate the remaining water. And after we'll obtain a powder that we will be able to use in our process in the liquid phase. Donc it's a bit like that. You will see some drawing. Donc first step is to aggregate, we can say, and protect, to have a single shell protection of a lipid globule in emulsion. And after we will re-encapsulate second time to have a double shell protection and cross-linking to be resistant to the process. And as I said, spray drying to obtain powders. Donc this is the composition. It's 60% of refined fish oil rich in DHA inside in yellow color. And all the other ingredients, fish gelatin and lots of antioxidants, as you can see, sodium ascorbate, tocopherol, ascorbic palmitate, for example. They are used to help to protect the ingredients and also during all the shelf life of these ingredients. Donc it's the reason why we add this encapsulated DHA to our EasyLac formula. Second very sensitive ingredients that you know very well also, iron. Donc as you know, iron is linked to numerous drawbacks when you put inside some infant baby milk powders, because you can have sensory problems with metallic taste. You can have technological problems, oxidation of fats and vitamins during the process, but also during the shelf life. And nutritional problems, because you can have poor bioavailability by binding to other ingredients, to other elements. Donc we use a micro-encapsulated and micronized source of iron to prevent from these problems. Donc you don't feel metallic taste in this case, because this micro-encapsulation technology avoid the direct contact from free iron to you. And no oxidation also on fats and vitamins, because it will protect against the interaction between free iron and the other ingredients, sensitive ingredients as DHA, as we said, for example, other fats and some vitamins, as you know, linked to vitamin C and other vitamins. So it will limit the oxidative capacity of free iron by protecting the interaction. And for us, it's easy to use because it's water dispersible powder with approximately 8% of elemental iron, which is sufficient to be able to adjust to formulation and to have the right amount of iron that we need. Now we can use these ingredients in various different conditions. Just to show you on this slide that it's possible to use on a very high temperature product, higher temperature process, like pasteurized and UHT milk, evaporated milk, and of course, as we are telling today, spray-dried milk and infant milk. Donc you know, as experts in medical parts, that iron is very important, and iron deficiency can affect some systems, like immune system, for example. Alors, just to remember, the immune system is impaired by iron deficiency because of the leukocytes. They will have a reduced capacity to kill ingested microorganisms, and the B lymphocytes have a decreased ability to replicate when stimulated by pathogens. So we saw that in some different studies. So it's very important, and WHO also demonstrated by the past the relationship between iron deficiency and impaired immune system. The same impact is also quite important also on cognitive development between anemia and only deficiency. Donc for infants suffering from anemia, it's very clear but we have some great deficit in IQ compared to their classmates. Some old studies showed that. And also, in case of deficiency, as you see on the second paragraph, you are able to come back to normal, but it's very difficult because, as you know, iron, it will take time to come back to normal by enriching the food. It's very, and the damages are sometimes not reversible. It's very important to keep an eye on it. And just to show you, to finish, efficiency study that was done with this ingredient on young women, because it takes part also on pediatrics, young women. Look, we saw that it was very efficient in terms of enrichment and supplementation with, compared to the reference group without. It was made on juices with iron supplementation or not, and it's quite efficient, as you can see in red, after a few weeks of use. That's the reason why we add encapsulated iron like that in our formula, to avoid all of these drawbacks. In order to finish, the last slide about the food safety, very important for you, but particularly also for us. We have a brand new laboratory with more than 100 persons, and they are performing more than 250 different controls on each batch produced to be sure that we can release without any problem. And every year it's approximately 1 million quality tests done, and we have more than 100 people assigned to product quality, approximately 14% of our total headcount. For us it's very critical, and it's the main purpose before releasing all the products to Saudi. Thank you very much.
Thank you.
Thank you.
Thank you, Dr. David. Thank you for our main sponsor. It was in-depth information. Now we'll found a factory. We will do a factory to compete with your company. Yes. Thank you. But we need cows. Yes, we need cows. Okay. Then, with no delay, we will start our next session. I will invite the moderator, Dr. Isa, and Dr. Najla, to start. Dr. Najla Abdulaziz and Dr. Isa, they will lead the session. Go ahead. توكلوا على الله. Thank you.
Many thanks to the organizing committee for inviting us. And it's a pleasure to be here with you all today. During this session, we will have 3 speakers. And with me and the moderator, Dr. Isa Sultan, consultant neonatologist at National Guard Hospital, Medina. We will start with the first speaker, Dr. Fahd Al-Aqel, who will be speaking on defining the edge of viability. Dr. Fahd is a senior consultant neonatologist at Care Medical Hospital. He completed Canadian fellowships in neonatal perinatal medicine and neonatal follow-up at the University of British Columbia. Dr. Al-Aqel has made major contributions to newborn care in Saudi Arabia, and please join me in welcoming Dr. Fahd.
Thank you. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for the moderator, and thank you for the organizing committee for inviting me for this prestigious meeting. I will talk today about the age of viability, the ethical and clinical perspective. Is it working? Yes. Okay, so I'm working on Care Hospital, which is the first hospital, a private hospital, started in Saudi Arabia around 60 years ago. And we have a small unit, but we are level 4, taking care of open heart surgery in neonates. And this is the first private hospital accepting open heart surgery in the neonatal ICU. So starting with the definition, of course, the challenge is when you are resuscitating or have a call to resuscitate a baby between 22 to 26 weeks of age, of gestational age, because there is a clinical and ethical and legal consideration, and this is not an easy. So what is the definition of age of viability? Of course, it is not an easy, because the question has been extensively discussed politically, legally, religious, philosophically, and scientific conversations to define the age of viability and what the meaning of viable babies. A single universal definition of the limit of viability cannot exist, because each baby is different, each setting is different, and each community also is different. So you cannot implement a definition which is from another country or another community, or even sometime from another unit. The almost 200 years ago, William Potts, who's the American obstetrician, defined the viability as the capacity to sustain life rather than the mere sign of this condition, which is very nice theoretical definition for the viability. But now, what is the definition we should use to define the age of viability? Is it survival to discharge, which is approaching or exceeding 50%? This is a definition which was taken by the North American, and although it is not clear what is the why 50% and survival to what? To go home, to pass neonatal period, to have the 1 year of age is not clear. In the UK, the definition was more clear, which is still not that clear. Gestational age where 50% survive with the modern intensive care unit. In the World Association of Perinatal Medicine, they define the age of viability as the age when sufficiently mature to survive, for the neonate to survive the neonatal period, which is 28 days. So if 50% of the babies will pass the 28 days, then this is the age of viability. So it is changing, 50% chance of surviving. So we are dealing with unclear definition to start with. And because of this, we are changing every time. In the 60s, we are doubting the 30 and 31 weeker. And on the 80s, we start resuscitating or talking about 26 and 27 weeker. Shall we resuscitate or not? In 2000, 24 weekers, and now we are talking about the 22 weeker. So it is changing with the time. 40 years ago, we are resuscitating the 34 weeker, and we are sure they will survive. Now we are talking about a 22 weeker. Shall we resuscitate or not? So why we need a clear definition? It is not only for the physicians. It is also for the parents, for the general population, the people, the parents, for the religious scholars, for the decision makers, and for the court. We need national clear definition for the age of viability. So until more accurate model of a neonatal prognostic are developed, gestational age remain the primary but not the only. And this is a very important point, not the only predictor for the guidance for the time or age of viability. So we still depend on the gestational age as the main and the most important factor. If we are depending on the gestational age, then we have to divide the babies to 3 groups. The too small or too immature babies who are usually, if you are talking about 20 weeks of gestational, have not survived as per the published or literatures, and few babies survived at 22 weeks, so they are too small to be resuscitated, and almost everybody agreed at this time that this age should not be resuscitated or offered the comfort care. On the other side, the too big babies and too mature, when we are talking about 24-weeker, in the high-income countries, in the good intensive care units, then there is a good survival rate, and everybody again agreed that this is, should be resuscitated, and we left it with the gray zone, which is the 22 and 23-weeker. So if you want to do a national level, deciding the age of viability, what are the challenges? Of course, there is challenges related to the maternal and antenatal system or care system in your country. You have to study the antenatal referral system and the maturity of the maternal system, the labor and delivery and neonatal care leveling, and the capacity of the labor and delivery and the neonatal, and the networking between the NICUs. Neonatal transport system availability is a very important factor to decide about the age of viability. Not only the availability of neonatal transport, but the capacity and the quality transport. The post-discharge medical and non-medical support for the baby, and the same thing, the support financially and non-financial support for the family. So what is the impact of putting a national definition for the age of viability? There is a medical, ethical, and emotional complexity. The ethical and legal dilemma, are we helping this baby or increasing the suffering of the baby and his family? The other thing is the undesired burden on the infant during and after the NICU, and the undesired burden on the health system during and after the NICU admission, and the undesired burden on the family during and after the NICU admission. If we will go through some of the international experience, most of the time we will remember Japan, and we will remember that Japan changed their age of viability definition from 24 to 22 weeks since 1991. And most of us, they will not know that even in Japan, not every infant born at 22 or 23 weeks will be resuscitated. Actually, in a study done in 2024, there was almost approximately 14% of those babies born at 22 weeks, and almost 2% of babies born at 23 weeks were not offered any resuscitation on the labor and delivery, and this is a decision was made in the labor and delivery. So it is not, although they have a clear definition of the age of viability, it is not mandatory, and still they will individualize the decision in 22 and 23 weeks. What about the United States? The American Academy of Pediatrics recommends an individualizing the approach between 22 and 24 weeks, and there was, this was since 2015, and there was last year a nice paper, a commentary paper published by an international group of neonatologists, ethicists, and parents advocate. Very nice paper talking about the decision of resuscitating less than 24 weeks. And the summary of this paper is we have to be clear with the parents about the outcome of this gestational age if we decide to resuscitate. And routine resuscitation of less than 24 weeks is not in the best interest of all infants. So we have to individualize the decision. We must address the methodology limitation of the neonatal literature talking about the outcome of premature babies, because sometimes they are grouping all the less than 26 or 28 weeker together and mislead the decision maker. And if you decide to resuscitate 22 or 23 weeks or even 24 weeks, you have to be ready for the investment on the long-term follow-up care and supporting the baby and the family. What about UK? UK in 2019 published their recommendation, which mentioned that you have to consider resuscitating 22 weeks, and you have to assess the risk and decide based on the risks. But based on this recommendation, most of the doctors start resuscitating every 22 weeks. So they make a clarification on the decision, which was published only 2 weeks ago, and it is now on the website, which they did very nice thing, which they divided the groups of 22, 23, and 24 weeks to classify them into extremely high risk and moderate risk group. And they recommend comfort care for the extremely high risk infants and survival focused care for the moderate risk group. So they are trying to avoid the unclear resuscitating of every 22 or 23 weeks. To summarize, most of the high-income countries' recommendations and the countries or societies or association, I put them in, most of them in this table. And as we can see, most of them will not recommend active resuscitation before 24 weeks. And either they comfort care 22 and 23 weeks, or there is no clear recommendation, or sometime no active individualizing the care for this group of age. So what about Saudi Arabia? Now, before talking about the medical side, we have to talk about the Islamic scholars' decision in Saudi Arabia. This is the famous fatwa that we are following in the neonatal ICU, and it was mentioned clearly that if the baby born after 6 months of pregnancy, then you have to offer what is the maximum support if it is available. And if they mention here the word wajaba, and wajaba, sometimes we are not understanding it nicely. In the Islamic meaning of wajaba is you have to, it is a must. In another way, it is prohibited not to do. So the word wajaba is, for me, need more clarification from the Islamic scholar if we have to mandate resuscitating of all those babies or not. The the remaining part of this fatwa is if the baby is less than 6 months then, of pregnancy, then 2 doctors will decide about the decision for the resuscitation. Now, in the there is a papers in the from the scholars published also. This is a very nice paper from Dr. Salih Al-Ghlega from the Imam University, and another paper from Dr. Asma Rashid, also from Imam University. A nice paper from Dr. Hela Liabis in the Imam University also. This is part of it. Maybe clarifying what is the more than 6 months of pregnancy and what is less than 6 months. And it was clear from the scholars that sometimes we are misunderstanding what is 6 months. 6 months, according to them, is 27 plus 2 days, not as we are thinking 24 weeks. So we have to revise this again. And then it maybe help us that if it is 27 plus 2, then it is mandatory and prohibited not to resuscitate. In 2014, we published our definitions, our national definitions, and those definitions were distributed, signed by the Vice Minister, and distributed to all the hospitals. I will not go, actually it was distributed to MOH hospitals, and also through the Saudi Council, distributed to the non-MOH hospitals. And I will not go through the definitions, but we have the perinatal period abortion definition, neonatal death definition, stillbirth definition, and this is the most important policy, which is the age of viability and resuscitation policy. So to summarize this policy, if the baby or the fetus born less than 16 weeks, you have to send the product to the pathology. You don't need to have birth or death certificate, and you don't need to register this product in the neonatal statistics. But if the baby is 16 to 21 weeks, then you have to send the product to the morgue. Again, no need for certificate or registration on the neonatal statistics. If the baby is, or the product is 22 and up to 23 weeks, and there is sign of life, then you have to register this product to the neonatal statistics, but we are not recommending resuscitation. If the baby is more than 24 weeks or 24 weeks and more, then you have to issue a birth certificate, and in case of death, a death certificate. You have to register the baby in the neonatal statistic, and you have to resuscitate. We also recommend considering the transfer at 22 up to 30 weeks, transfer the mother to a tertiary center. And if the gestational age is not clear or not established, then you have to resuscitate based on the weight, which is 500 grams at birth. So despite the policy, still the resuscitation of age of viability is a challenge. There is a study which was done, survey done in 2014, requesting an answer from a neonatologist about the age resuscitation of 22 up to 24 weeks. And the conclusion was there was a strong recommendation for comfort care at 22 weeks and for resuscitation at 24 weeks, with the individualizing 23 weeks. Of course, there is a cultural, social, and legal consideration when you are deciding about the resuscitation. We distribute, actually I did a survey, which was, we collect the reply, but we did not publish the paper yet. So I will present some unpublished data, which is from a survey which distributed to all the nationally to all the NICU staff. We asked them about 5 clinical scenarios. What you will do in case of 22 weeks non-vigorous male, 22 weeks vigorous female with antenatal steroid given, 23 weeks non-vigorous male, 23 weeks vigorous female with antenatal steroid given, and 24 weeks regardless of the age, or regardless of the sex or steroid. And actually, I received the reply from more than 1,000 reply, most of them from Ministry of Health. Of course, we are sending it to all the NICU staff. And this is national, only in Saudi Arabia. So anyone who is outside Saudi Arabia excluded from the study. And we ask the question, I will not present the whole things, but the most important things, we ask who's making the decision if you are dealing with 22 to 23 weeks. And most of the answers said the neonatologist. So based on this, we decided to go to the neonatologist. There was in the reply from 194 neonatologists, and they are from different areas in Saudi Arabia. We asked them the same question, who is deciding? And 90% said neonatologist is the one deciding about the resuscitation. Okay, so the decision, most of the neonatologists, actually 175 replied that they will offer
comfort care to at 22 weeks. Some of them will give full resuscitation. If in a male who is not vigorous and no antenatal steroid. For the other side, there was increase on the full resuscitation when we are dealing with 22 weeks and female vigorous and the antenatal steroid given. For 23 weeks, we find most of them will resuscitate 23 weeks, regardless of the vigorous steroid given or not, with slight difference between the two groups. And in 24 weeks, which is for me surprising, not all of them will resuscitate 24 weeks. There is almost 15% of the neonatologists who are making the decision will not resuscitate 24-weeker. If I don't know why, but maybe because of the weight, they will offer different modes of resuscitation. So we ask the question of what is the main factor influencing your decision, and we asked the neonatologist, and the surprise thing was here, estimated fetal weight for the doctors is more important than the gestational age. And I think there is a difference really, which is surprising difference between the two things. I was expecting gestational age is the most important, and the recommendation is gestational age. Despite that, the consultant are looking to the fetal weight. So to conclude, do we need to revise or change our policy? I think yes, because number one, we are more than 10 years from the previous policy and recommendation. Number two, there is some conflict, which is the 16 weeks, product of 16 weeks. Some of the Islamic scholars were unhappy to be sent to the morgue, to the morgue, and they said 16, 17, and even 18 weeks should not be sent to the morgue and should be sent to the pathology, because still لا يوجد نفخ الروح أو نفخ الروح لم يتم. This is another thing which we need the Islamic scholars to be with us on this decision. Furthermore, for my personal opinion, I think still we should offer comfort care for 22 weeks, and we should individualize 23-weeker and continue resuscitating 24-weeker. We are in the process of publishing the national policy and recommendation. Hopefully, it will be published on the same paper. So these are my references, and thank you.
Thank you, Dr. Fahad, for your excellent talk and comprehensive overview. We will keep the questions at the end. We will move to the second speaker.
Bismillah ar-Rahman ar-Rahim. It's our pleasure to introduce the second speaker, Dr. Iman bin Salih al-Salami. She is a consultant in maternal and fetal medicine. She is an assistant professor at Imam Abdul Rahman al-Faisal University, and her interest in fetal medicine. Welcome, Dr. Iman. Thank you.
السلام عليكم. مساء الخيرات. ما شاء الله تبارك الله. It's a full house مع إنه بعد الظهر وبعد الغداء، فما توقعت ما شاء الله لا حول ولا قوة إلا بالله. Thank you very much for the scientific committee for inviting me, and for the organizing committee for this amazing gathering. It's always a pleasure to go somewhere and present, especially when it comes about fetal interventions. I have no conflict of interest to declare today. And I'm going to take you today with me on a journey. We're going to dive together into the fascinating world of fetal intervention, where the patient is tiny and the stakes are high, and the intervention happens before the first cry. Think of it what you do, neonatology, but with a head start. Now, these two hands holdings, it's from a case that was done in Cleveland Clinic. It was a few years ago in 2021 where an amazing team of multidisciplinary people came together and they opened the uterus, took out a baby at a 26 weeks gestation, happened to have a pericardial tumor. They removed the tumor, put the baby back, and closed. And the hand here is Dr. Hani Najim's hand, where he was leading the cardiac surgery team, and he put the intravenous cannula in the right hand for 26 weeks. It's amazing for us, but you deal with those 24, 26 weekers in hands anyway, and you do this almost every day in your specialty. But we're not here to talk about Dr. Hani Najim or a fascinating surgeries that newsworthy. We're gonna actually ground ourselves in the current fetal therapy that we do every single day and examine what are the ethical dilemmas and institutional challenges that we face along that way. And also maybe have a little bit of faith in what we do and look forward to what's coming ahead from a fascinating and an amazing frontier in fetal therapy. Now, what is fetal therapy? It's any intervention that can happen to the fetus antenatally. It can be as simple as medication or supplementary diet to a complex open fetal surgery in utero. Now, why do we do this? When it comes to fetal intervention, it's actually led by one principle that evolves around it, one central principle, that the fetus is a patient whose condition evolves dynamically and throughout the pregnancy. And every or most and majority of fetal conditions, either congenital or acquired, has this critical window of reversibility. And if we intervene in that window, then we can reverse the outcome, either cardiac remodeling or pulmonary hypoplasia or whatever. And if we miss that window, then we're gonna have an irreversible outcome for the fetus. Now, what we wanted to do when we treat the fetus is actually provide you with the best outcome you can manage that baby after delivery. So instead of dealing or becoming reactive to the fetus or the neonate, where we want to move into a practice with a proactive management antenatally. Now, I put this here, and I know you might not be able to read it because of the font, but it's the original article that was published in the early 1960s. And it was one of the first fetal therapies that was published in the literature, and it was done by a New Zealander obstetrician, Albert Lilly, where he did an intrauterine transfusion in 1963, and he published it. And you can see the image here that it was done under X-ray. So he injected the needle, did an X-ray, made sure it's in the peritoneal area, and transfused blood, and the baby delivered a few weeks later and didn't die. So why I share this with you here, because it actually emphasized the point I just talked about, and it's amazing. I want you to hear this. I'm gonna read it. He wrote the aim of the exercise, and he meant by the exercise is the intrauterine transfusion he did, is simply to arrest deterioration if possible. He wasn't even sure of his intervention, and gain a few extra weeks of gestation so that the skilled pediatric care of severe hemolytic disease is not nullified or stumped by gross prematurity. So that's the goal. We're trying to give you the fetus or the baby in the best condition possible. Now, since Lilly introduced the intrauterine transfusion, fetal therapy field evolved and evolved rapidly. We moved into doing open surgery and then doing laparoscopic surgeries and doing minimal invasive until recently one of the cases was done at King Faisal Specialist Hospital and Research Center in Riyadh, where they did a fetoscopic meningomyelocele repair in Saudi. But from all that, I wanted to share with you one of the major landmark cases that was done by Michael Harrison, where he first introduced the actual fetal surgery. He saw a fetus with a major urogenital problem, and then he practiced the procedure he wanted to do on the animal, and then moved it to the fetal, and he did it on a live fetus, and then the fetus survived. The idea there that he actually introduced the concept of that we can operate on that tiny patient and then get a good result and outcome eventually. Here's what fetal therapy span to or mean. It can be, as I mentioned before, non-invasive therapies, which is basically a supplement or medication, and one of the major ones here is the folic acid and B12 that we give specifically folic acid for patients to prevent open neural tube defect. And then there are some medication like a rate of rhythm control, or like digoxin or others that we can give to the mother and hopefully correct the fetal rate. Now, these medication can be given without a direct modality to introduce to the fetus, like giving it to the mom and then passes through the placenta, but it also can be introduced directly into the cord and the fetus. Now, one of the major shifts in treatment or perinatal care was the corticosteroid therapy or treatment, and you all know that. We love it, you love it. Now, Leggins and Howie, they published their landmark trial. That's every fellow in NICU or neonatology and maternal fetal medicine should read the original one. And they published it in 1970s, where shifted the management and proved that steroid or corticosteroid can actually enhance fetal lung maturity in a preterm babies. And then the studies came right after. Who can guess why I put the Cochrane Library logo here? What? Because the forest plot used by the Cochrane Library, it's actually represent the corticosteroid studies or clinical trials in the meta-analysis to prove that evidence-based medicine exists and change practice. So the logo you see for the Cochrane Library, it's a study from the perinatal medicine, or that's actually was one of the greatest studies in medicine in general. Now, in the table, I didn't mention a lot of the things, but we're gonna go some of these interventions one by one in the next few slides. One of the ones is, as I showed you, Lily did it on using an X-ray. Now we do intrauterine transfusion using direct ultrasound. So you can see here I don't know if this is, you can see here the needle comes into the cord, placental cord insertion, and then we transfuse the fetus. This is the standard of care for alloimmunization and fetal anemia. And the survival improved 90%. But this is not gonna last for long, because now there's this new clinical trial going on right now. This is the phase 2 of the clinical trial that proven that nipocalimab can actually prevent almost 50% of intrauterine transfusion in babies who are alloimmunized and women who had previous babies with anemia. Now, this is the phase 2, and we're going through phase 3 clinical trial for the Azalea, the nipocalimab trial, and Saudi is involved in this trial, and I bet after this trial is published, it's gonna be a landmark trial. It's gonna shift the management of how we treat babies or pregnancies with a history of previous history of alloimmunization and previous fetal anemia. Now, laser photocoagulation for twin-twin transfusion. We know the Eurofetus study shifted the treatment for these cases, because before, babies with twin transfusion used to be treated, or pregnancies used to be treated with serial amnioreduction. This is another shift in the management of how we manage these babies by the Euro fetus trial, where proven that doing laser improves survival significantly, and now this is the standard of care. We see here the fetu procedure, where we block the trachea of the fetuses who have diaphragmatic hernia to hopefully improve the lung expansion. It's using the secretion of the alveoli in lung to improve the lung maturity. And here you can see it's a minimal invasive procedure that they put the scope, go through the mouth, tongue, and then all the way down. I'm going to show you, and then you can inflate. And you can see here, this is where going is through the lips, going into the mouth. And it's narrow, but that's the tongue down at 7 o'clock. And then they go in. It's going to be better. It's going to be clear once they're in the trachea. And now they go in. And once they go in the trachea, they identify the bifurcation. They go back a little bit, and then they deploy their balloon, inflate it, and they go out. And they're going in, and you can see down the hole for the bifurcation, and that's where their balloon is coming in. Now, this trial, it's actually the one that showed improvement in these babies, but it's still not widely adapted because of the challenges that we're facing in these cases. They have more than almost 50% of the cases had rupture membrane and complicated by early delivery. The shunts are simple. Theoretically, we struggle with it. And we struggle because they're complicated in a way that they need a follow-up, they get blockage, they need replacement, but they're still used in some of the severe cases, and they've proven beneficial. It's interesting how when it comes to treating open neural tube defect in utero, it was first introduced in 1997 at Vanderbilt. But it wasn't widely accepted at all until the MOMS trial came out in 2011, and then it became acceptable, and it showed improve in these cases. And you can see in the first ultrasound image, maybe some of our colleagues who attend our perinatal meeting, they can read the ultrasound with us. So you can see the opening of the open neural tube defect in the upper image, and then once I go down, this is the image after the repair. You can see it's closed and it's not as open as one, and this is the same baby after delivery. And then radiofrequency ablation in some cases where in twin transfusion or complicated monochorionic, where one of them can be terminated, we use the radiofrequency ablation, or we use the occlusion and bipolar coagulation in these cases. Now, I left the last two because it comes into the ethical dilemma, when to do it, how do you do it. It's a lot of, when it comes to fetal treatment, whose health is superior, the mom or the fetus? So the Shervinack and McCall made a fetus as a patient framework. So you look at, is the fetus as a patient? So is the proposed intervention beneficial to that fetus, and the benefit outweigh the risk? And what is the autonomy of the mom? What does the mom want? Does she want the intervention? Does she not prefer the intervention? And believe me, some patients, even when the fetus is hydropic and we want to transfuse, they completely decline. It's like, I don't want. And part of it, and we know that part of it is they're scared of the outcome. Even if we transfuse, is the baby going to be okay? Is the hydrops going to resolve? Is going to be a residual neurological deficits, for example? That's all they worry about it. So we do respect that. And then make sure that your consent is complete and informed consent is documented. So we put a framework when we discuss this with our patient. What is the natural history of the disease? is the fetus going to die or become hydropic? Or if you intervene now, it's the same if you intervene postnatally, so we won't make a difference. So what is the natural history of the disease antenatally? And then what are the risks that carried with the procedure you're proposing or the treatment you're giving to the mom? If you're giving her digoxin or you're giving her anything, what are the risks that carries to the mom and the baby as well? And then what's the timing? When are we supposed to do it? Are we missing the window of opportunity or not? And then make sure that you involve everybody in your team, that multidisciplinary. So I always brag about this, but I'm 100% sure that it's been done everywhere. We do a monthly perinatal neonatal meeting where we discuss the cases that are expected to deliver within the next few weeks. And we present these cases with the ultrasound images, and if we did MRI, and then we individualize the care. And then we invite everybody. Everybody comes into this meeting: neonatologist, pediatric surgeon, pediatric neurosurgery, all the pediatric subspecialties that involved with fetuses, pediatric cardiology, and then we get the input from them, and genetic as well. And then fetal therapy, practical challenges. We know that a lot of referral, like in Al-Haras, for example, or in other university hospital, we don't see those patients until it's late. So we have missed that window of opportunity. And then sometime when they come, we don't have the actual, we're not prepared to see these patients for whatever challenges, that institutional challenges that we have. And then maybe we're not trained enough. For example, in our center, we do not do some of these procedures. We don't do the laparoscopic meningeomyelocele. So even at التخصصي, for example, in Riyadh, they do need certain cases to keep their privilege and then to keep their skills up to date. And then how do we follow these patients? They come from Al-Hassa, they come from Riyadh. Are they coming back for referral? How often do we need to see them? Do we provide for them care as an outpatient, proper care as an outpatient with home care delivery? All these things need to be kept in mind when we talk about a full center for fetal intervention. And then documentation and communication has to be clear with the parent and the family and in the medical record as well. I hope one day we see this where we don't stop only at the perinatal neonatal meeting, but we carry the care to be personalized for every fetus, because now we are at the era of personalized medicine for people. I'm hoping that we get to that point even for the fetus as well. Believe me, the gene therapy and CRISPR gene addition, it's not science fiction anymore. It's happening now. And there are trials going on right now as we speak on SMA and hemophilia. There's also a stem cell transplantation studies done, and it's been done on a patient for skeletal dysplasia cases. So we are living in the future right now. The future that we thought it's not coming, we're living in it. So I think it's time for Saudi now, in Saudi, to move into getting ready our institutions to have these advanced procedures, and I think we do have the capabilities to do this. Fetal therapy is advancing and advancing quickly, and we do have the human capabilities, we do have the institutional capabilities. We just need to make sure that we come all together. احنا الان we're focusing على if Riyadh is going to do, لو الرياض بيسوون الفيتال intrauterine fetal surgery, then we will support them. We will send all the cases to them. If مثلا احنا we want to do intrauterine transfusion, then we want everybody to send cases for us to build our capabilities at this time. I know some people think, maybe it's not the right way to go to centralize care for certain cases, and maybe each center have their own مثلا care for all type of cases, intrauterine procedures for all the cases, ولا for OR for operation for all the cases. That's something that we can sit together and discuss and talk, and طبعا considering the NICU capabilities حقت كل center for sure. Because when we talk about what we can do, لازم نفكر, we have to always think about, can we deal with the complication that might arise from that intervention? If our NICU is not ready to receive a baby at 24 or 25 weeks, then I shouldn't be a cowboy or cowgirl and do procedures for those babies that she might deliver in a few days that's she maybe could have completed her pregnancy until 34 وبدل ما أعطيهم 34 with a problem أعطيهم preemie with a problem. So I think we always have to think about these things, but at the end it's coming, it's here. I think we should be ready for it, and thank you very much.
Thank you very much, Dr. Iman, for the nice lectures and informative. I think now we open the floor for the questions till the third speaker to be ready. And still there is like 15 minutes for questions. Dr. Fahad, you can come here. Doctora, please. Any questions or comment? Yes, Dr. Zakaria. جزاك الله خير. الله يبارك فيك. عندك just give the mic to Dr. Zakaria. Doctora, mic. Dr. Zakaria.
I would like to thank both speakers, but I have a comment or a question mainly to Dr. Fahad. And I know, Doctora, you have already experience in this as well, although your lecture is different than what Dr. Fahad spoke about. But it will be in the form of comment rather than a question. It will be in the form of comment, but I would like also your comment. Now, when you speak about the age of viability, we have been speaking about this for a really long time. Since I was trained and I didn't know what to do when I became a consultant, because is it 24, 22, is it 23, is it the weight, is it multiple things? But with time, I realized one thing, which is, I think it is the mindset of people who are attending the delivery. You have the antenatal magnesium. There should be a mindset antenatally with the antenatal magnesium sulfate or what you showed in the Cochrane about the antenatal steroid. So there should be a comprehensive, complete team that is not only powered with equipment, but also powered with enthusiasm and the mindset to really try their best for those 22 and 23 and above. We're still suffering in some places about 27-weeker and so on. And not because of the lack of equipment. I don't think it's any more lack of equipment. I think it's a lack of mindset to really help those patients. So I'd like to hear both of your comments about this.
Thank you. This is a really nice comment. I think, as we mentioned, it is a complex thing. It is many factors, not only the, as you mentioned, the enthusiastic. It is the capacity of your team, the capacity of the readiness of the family, readiness of the government to support this patient during and after admission, to support the family during and after admission. You are going to discharge at 22 weeks or 23-weeker. Who is going to support him for the rest of his life? So this is very important factors. Plus the, of course, the transport team, the labor and delivery, the networking, the transfer on time. All these are very important factors. You cannot resuscitate a 23-weeker or decide to make the age of viability 23-weeker, and then you will have a trouble and a problem in the north and west and so on. So you have to make a decision if you are making it for national, for the whole country. And this is not an easy thing. Of course, yeah. The development, the follow-up, neonatal, I think the high-risk follow-up and developmental follow-up is very important factor. Doctora, comment?
Sure. I'm going to comment from our perspective as an obstetrician. It's nice to know that you guys agree on something عشان إحنا نعرف يعني. and it's always multiple factors. أول حاجة زي ما ذكر سعادته إنه صحيح الgestational weight، بس إنه إحنا نعرف the limitation of ultrasound when estimating fetal weight. There are limitations, and we always say plus or minus 500. أنا MFM and يمكن أكون أكثر واحدة أقدر أعطيكم accurate, and it still doesn't come close to what we estimate. So this is something that we know it's flawed. الجستيشنال age ممكن الناس كلها ماسكة فيه لأنه it's the only thing that we have, but also it can be flawed as well. إحنا مو كل المرضى يجون ب early ultrasound to confirm the gestational age. So تجيني تقول لي at 25 weeks and it end up لما يطلع لكم وتشوفون وتسوون الإكزام تقول لي دكتورة والله 22 weeks it looks like. So sometimes these are actually also not يعني البارامترز اللي we deal with it's not accurate to start with. And not because it's anybody's fault, it's just the system that we're here. It's fragmented. Patient goes to primary health care somewhere and records are not transferred. Maybe she didn't even see anybody أصلاً. إلين ما جات عندنا. So this is the first part. The second part, I think it's important, you alluded to it. It's good if there is an institutional policy دائما deals with preterm. Clarify exactly the steps. حتى لو قالوا بس إنه for each one, an obstetrician should call a pediatrician to decide case by case. So I call him, I say, this is what I have, this is how sure I am, what do you want? Do you want to resuscitate or not? At least to give me an idea, because if he said we're not, then I'm not going to monitor that baby. It reflects on us as well. I'm not going to give that baby steroid for fetal lung maturity. I'm not going to give that baby magnesium sulfate. I'm not going to do all these things. And also it has to have something in the policy says everybody comes in after 24 weeks to give them steroid for fetal lung maturity, to give them magnesium sulfate for neuroprotection, to give them, to be clear that if a resident is there or a trainee or a specialist, they don't have to guess it's there. So it's multiple things, but also I always say, إن كل NICU غير، كل NICU عندهم السرفايفل ريت حقهم، وNICU عندها 5 أسرة غير عن ICU عندها 40 سرير، always individualize.
Thank you much. بروف صاعدي تفضل.
These important issues regarding the importance of the presence of institutional policy. I think that's very important. I remember in our hospital in King Faisal Specialist Hospital, Jeddah, at one point among us as a neonatologist that 24 weeks gestation we restate or 500 grams. So one day, twins did, according to the gestational age, 23 weeks. One of them 500, the other one 420. So the neonatologist on call decided to restate both. Another neonatologist who received it from him the other day said, why you restate? We didn't agree to restate 400, particularly that the gestational age 23. Then we changed the policy and we said 23 to less than 24 is a combined decision of the consultant neonatologist and the consultant obstetrician. After 24 weeks, we restate. Besides that, the importance of presence of institutional policy or guidelines, I think from medical side, medical legal side of view, is very important. I think I urge that every institution should have internal, we'll say guidelines or regarding this, because medical legal, I think, very important. Regarding the, just a comment, Dr. Fahd, regarding unit doing neonatal surgery in the NICU, I think since 2001, we'll do it in King Faisal Specialist Hospital, Jeddah. A matter of fact, BDA ligation, sometimes we'll do it in the NICU if the OR is busy, as well as sometimes the patient goes for BDA ligation. Open heart surgery will go to CSICU, but once they close the chest, it comes down to the NICU. Thank you.
Thank you very much. Ready to do comment? Thank you. Yes, Dr. Jubara, please.
Thank you very much for both speaker for fabulous presentation. Again, my question regarding the limit of viability. We know all these guidelines and even like the scholarity opinion it was more than 10, 11 years ago. So it's, you know, medicine and neonatology has been really changes. Like 10 years ago, the survival and morbidity of 27-weeker was different than from now. Facility improving, training has been significant improvement in training, equipment, everything is really available. We heard this morning about MIST, LISA, you know. So I think we need to have an updated recommendation from all aspects, medical and non-medical, you know, for this limit of viability. I do agree, at this stage, it's not comfortable to leave 23-weeker, especially in the higher centers where even the follow-up, you know, is there. So if I put, for example, general guidelines, 23-weeker, not to restate below 23-weeker, so it will be very difficult to really apply it. Our kingdom, it's variable. You have a level 4 in ICU, and you have very limited level 1 in ICU in the periphery. So I think this point should be taken in consideration. The other thing is the mindset, as what Dr. Salam mentioned. I think we need to work on that from both obstetric and neonatology. So having guidelines, having a meeting or call and decision before the delivery of each these cases. You know, we don't restate 22-weeker, but they admit a patient to us. They did not call us, and when she was 23, because our local guidelines is 23, she did not receive steroids. You know, so it's really very complex. But we need to have a decision from all aspects, including religion, you know, scholarity, because this, like the definition, it's more than really 11 years, and we're still following that. Last thing is the medico-legal aspect. I received several calls in life-saving. They resuscitate 22-weeker in the peripheral hospital, and they call me for transport. So I asked the doctor why. He said because they will complain. The parent will complain. Again, putting a lot of you know, hazard on the physicians, on the transport team. You cannot leave a living child 24 hours because of 22 weeks, leave him in that periphery. So you need the transport, you need to send him to other tertiary in ICU. So I think the medico-legal aspect also in resuscitation of limit of viability need to be addressed and in urgent really matter. Thank you.
Thank you, Dr. You need to do.
Okay, just a short comment. You mentioned a lot of things. I cannot comment in, but medico-legal, we put the clearly, and this is hopefully solved in 2014 when we put the definition. There was no definitions in Saudi Arabia. Since 2014, there is a clear definition. So you can use these definitions, which was approved by Ministry of Health in the court. For the resuscitating of 22 weeks, nobody will ask you in the court why you are not resuscitating. So there is a clear definition from Ministry of Health, and nobody will say anything, supposed to be, because this is a policy, the national policy. A lot of discussion about this, but I will not go through it. Now, do we need to change? Yes, we need to change, but I will tell you a secret. I was communicating with the BABM actually last 2-3 months when they are updating their policy. I have a comment on it and I send it to them. And the main reason they will update it is because they are resuscitating every 22 weeks and they are not happy. They want to individualize and reduce. So we are not going more resuscitation, we are reducing the, so this is why they put it in categories and leveling, so the people support the decision when they are deciding in the middle of the night, this is high risk, don't resuscitate, just give comfort care. So yes, we are in 2025, but I think till today, we should not, we should think really of whom we can resuscitate
and whom we should just give a comfort care.
Thank you, Dr. Fahad and Dr. Iman, for the excellent talk. And we will move to the third speaker. She is waiting for us to start. Dr. Michelle Barton-Varbs, an associate professor and division chief of infectious diseases at the Children's Hospital London Health Sciences Centre in Canada. Dr. Barton completed her postgraduate training in pediatrics at the University of the West Indies, Jamaica, followed by clinical and research fellowship in pediatric and transplant infectious diseases at the Hospital for Sick Children at Toronto. She will be sharing her talk about universal congenital CMV screening. And welcome, Dr. Michelle.
Thank you for having me. I was asked to give a talk on congenital CMV, and so I will be talking about CMV as it relates to the various changes that have taken place recently, in particular around treatment and the emerging data that suggests preventive strategies can be applied in the antenatal period. So today I hope to summarize the epidemiology and seroprevalence and quickly review the symptoms and signs, and then and the diagnostics, and then quickly go into the changes in management. So congenital CMV is very important because it is the leading cause of non-genetic hearing loss, sensory neural hearing loss. And it is the most common congenital infection that we see. It accounts for roughly 0.67% of live births in North America and Europe, but in developing countries, it can reach to as high as 6%. In Canada, our rates run less than 0.6% since we've started our population-based screening in Ontario. Our numbers are much lower than that, than the 0.6%. In terms of the epidemiology, you know that this is a virus, it's a beta herpes virus that basically has lifelong latency in humans. And in fact, it is very common for an adult reproductive woman to be already positive. So ironically, even though primary infection in the mother is highly associated with the likelihood of getting fetal transmission and congenital infection, the patients who have non-primary disease that is acquiring it probably in childhood or in their teenage years, when they get into pregnancy, they have a lower risk. But cumulatively across the world, most of our babies who have congenital CMV will have it from reactivation of non-primary disease in their mother. We'll go over that a little bit more. I know it sounds a little confusing, but I'll mention it a little bit more. So this just shows the global distribution in terms of seroprevalence with countries, as you can see, like Asia, having high seroprevalence greater than 90%. So the developing world tends to have higher seroprevalence and the rest. So why is congenital CMV important? This is the point I want to highlight. The main reason, even though we talk about the small 10% that have significant neurodevelopmental delay, what is most concerning is that this is an important cause of sensory neural hearing loss. And in the first circles, the first circle, you see the contribution of CMV at birth to hearing loss, and it accounts for 1/5 of babies with hearing loss will have CMV. And then you see genetic causes are quite important. But the important thing about CMV is that even if the babies get off the hook at birth, they still have a risk of developing late onset hearing loss. And you see in the bigger circle to the right that when they looked at children 4 years and older, looked at children 4 years old, they saw that CMV was accounting for still a significant amount of hearing loss. So there is progressive hearing loss, and you see the breakdown that whereas in the newborn, 10% of that hearing loss is clinically apparent. In the 4-year-old child, you see that it's kind of split between the clinically apparent infection being only 7%, and then the clinically inapparent 8%, and then 10%. So you end up getting an additional 10% over the 4-year period that develop late onset hearing loss. So among newborns, you will see that 7%, so this is asymptomatic newborns. So you will see that sensory neural hearing loss is present in 7% of babies by 3 months. And then by 5 years, it's 14%. And by 18 years, it's 25%. So it's a progressive increase. And then, so the hearing changes that you see, what we do know is that the hearing loss that comes on later is not as profound as the one as the subset that we see in the neonatal period. And then the hearing changes can be asymmetrical. And in a progressive hearing loss, this is isolated hearing loss, as opposed to in the newborn period, we can get hearing loss along with the other constellation of the congenital syndrome. So overall, what we are looking at is 40 to 44% of symptomatic congenital CMV, babies with congenital CMV will develop sensory neural hearing loss. And so, whereas amongst the asymptomatic group, we're talking about roughly 10%, 11%. So it's important even in the asymptomatic. And this is how you counsel your patients. Even if they look good at birth and there's nothing to find on the investigation, you still have to prepare them that 10% of their babies will end up with hearing loss. And that's why you need to continue to follow them beyond the neonatal period. And then the other important aspect that we all know is the neurodevelopmental sequelae. So the neurodevelopmental sequelae, we're looking at in the 10% that are symptomatic, 90% of them will end up with neurodevelopmental. So whereas neurodevelopmental delay is rare in asymptomatic babies, is 5 to 15%, although this data is evolving because this data predated us doing universal screening. Now that we're doing universal screening, we're picking up all the babies, and now we've progressed to doing more MRIs. We're seeing that even babies that we thought were asymptomatic and didn't have even had normal ultrasounds end up still having white matter changes on the MR. So this basically shows that this is a nice figure that compares the first trimester, if congenital CMV occurred in the first trimester versus later, the impact. And we know that obviously the babies who acquire the infection in the first trimester are at a highest risk of all the consequences. And then this basically shows a survival curve for babies over time who acquire the infection either because of a mother with secondary non-primary infection that reactivated versus primary infection. So how is CMV transmitted? So we know there's horizontal and vertical transmission, and basically, horizontal and vertical transmission. And the horizontal transmission, takes place even though we say blood transfusion, and that's probably that we screen our blood, so that's not as the more important thing is the intimate contact with infected body fluid and sexual intimacy. The intimate contact is probably the most important point to highlight as it relates to mothers and their exposures, mothers who work in daycare or mothers who have many young children. They are prone to getting primary infection if they don't have it, or to get new strains of infection. So even if you don't have primary infection, if you had infection from in your childhood, because you have different strains of CMV, you can get a new strain upon your old strain, which makes your risk a little bit more than just the non-primary infection. The CMV vertical transmission can take place in utero or around the time of birth or postnatally through breast milk. We're not so worried about postnatal, although new data emerging is showing that the postnatal infections, particularly in the preterm babies, can be quite challenging in the newborn, in the neonatal unit, with significant transaminitis, pneumonitis, and even neck. Okay, so primary infection, when we talk about the maternal infection, we want to establish that it's either primary or non-primary. Non-primary means they had it earlier in life and it's just reactivating in the pregnancy. So what are the risk factors for maternal CMV? So mothers who have multiple partners or mothers who interact with young children are probably the highest risk. Recognizing this, then it is important to note that we can prevent. There are some preventive strategies that we can apply, and it's important to educate our mothers to avoid or reduce exposure during pregnancy to children who are shedding. But there's new data coming out in terms of secondary prevention. Even if the mother ends up getting primary infection in utero or in the periconceptual period, there is role emerging data that suggests there's role. We'll look at that. So the preventive strategies I mentioned to reduce, avoid new partners and be careful with hand hygiene and don't share utensils with young babies. So this trial basically established the role of, this is the vaccine, emerging vaccine trials are going on. No vaccine candidate has been approved yet, but they're in various phases of trial and promising. In terms of the trial that established the role of antiviral in mothers with primary infection in the first trimester, this trial published in 2020 showed that valacyclovir was effective in reducing the rate of fetal transmission if it was given early in pregnancy and continued through until amniocentesis. And this is a meta-analysis that combines 3 trials, and it came to the conclusion with a total of about 500 study participants. It came to a conclusion that 8 grams per day of valacyclovir reduced the vertical transmission rate in these mothers with early trimester infection. So there are consensus guidelines that have recently been published for the UK, for Europe, which basically emphasize the use of these strategies in mothers. Okay, so when should we suspect congenital CMV? Obviously, there are antenatal clues, and in the European guidelines, they now recommend routinely testing mothers in their first trimester, early in their first trimester, for CMV, IgG, and IgM. In Canada, we are still we're not doing preemptive testing. We're testing in response to findings in the antenatal period. That is, suggestive fetal ultrasound findings. Bowel thickening is probably one of the common reasons why we'd screen a mom for torch infections, and all things being equal, congenital CMV would be high on the list. But these are other causes to screen. And then, of course, everyone knows that obviously if you have a baby born with a constellation of symptoms that is suspicious for congenital CMV, then we would also screen those babies, or if a baby has isolated hearing loss. So those are the reasons to think about it. The findings for CMV are well described. I'm not talking to folks that don't know, so I'm just going to skip quickly over this. But it affects multiple systems, and it basically can mimic sepsis, but it mimics other congenital infections. This table basically summarizes the clinical findings but highlights the abnormal lab findings. I would highlight significantly the thrombocytopenia. Thrombocytopenia is an important marker, and we strongly advocate that in the NICU, even though there are many causes for thrombocytopenia in NICU. When you have a baby with persistent thrombocytopenia, certainly a baby who, we used to say, when we have a baby with persistent thrombocytopenia, one who's requiring frequent transfusions, you should ensure that you have done the CMV screening on the baby, urine CMV on that baby. However, we've started to do it even on just any baby who has thrombocytopenia at birth, and we have been surprised to see how many more we are finding. Okay, I'm just going to quickly, or maybe in the interest of time, I won't I'll just quickly highlight this because it was an interesting case that we had. Infant born at 26 weeks, and transferred to our institution at day 2 as a sepsis with on AMP and GENT. Sorry? Oh, I thought I heard somebody saying something. The baby was symmetrically small and had respiratory distress. You note the platelet count is low at 50, and you note there's transaminitis, both AST and ALT, and the Billet is 90, and it's mainly direct. So the direct hyperbilirubinemia is definitely a clue, along with the thrombocytopenia. And LP is done, and the baby is noted to have 21 white cells, acyclovir is added, thinking, common things being common. However, on day 4, there's worsening respiratory status and falling platelet counts to 25, and the transaminitis is slightly worsening, and the chest x-ray shows bilateral infiltrates. Basically at this point, the team had not really started to think about torch infections, but they really should have. However, fortunately for them, they got a call from the pathologist who informed them that the placental findings were suggestive of maternal CMV. And so based on that, they sent off confirmatory testing and started empiric antiviral. Question though, which antiviral would you have started in a 26-weeker who is in respiratory distress? Well, for sure, ganciclovir, because we need some IV therapy here. So even though Valgan is the treatment that we will use routinely in congenital CMV, the indication for IV therapy would be any baby who is not able to take oral or who is extremely sick. And this is an extremely sick baby, preterm, who needed IV therapy initially, eventually was transitioned to oral. And so All right, I'm just going to skip over that. The take-home point from that case was that congenital CMV rarely presents as an overwhelming sepsis picture, but in this case, the baby looked quite septic, and what was really contributing to the respiratory distress was pneumonitis. So severe thrombocytopenia requiring multiple transfusions should trigger the thoughts about CMV. As well, we've had really bad necrotizing enterocolitis, and sometimes you can get a pancolitis with perf. That you should, any in patients who have like significant pancolitis and they're thrombocytopenic and stuff, and think about doing a urine CMV on those babies. So what diagnostic test should you do? Well, urine CMV, of course, and it must be done early. And that's why we say as soon as you start seeing thrombocytopenia, just do it. Because by the time you wait until after 21 days, it becomes a blurred picture. You don't know if it's postnatal or if it's congenital. The other testing that is available is saliva. The saliva CMV PCR performs very well, as does the urine CMV, and is less invasive. However, the challenge is that it basically, you can get false positives if you don't wait at least an hour after breastfeeding. So we, in our population-based screening in Ontario, started off with urine CMV, and then we added saliva screening to optimize our pickup, because the dry blood spot test, which we use for screening, we started off using that for screening, has a low sensitivity, as you can see. We have a high performance one that can take us to almost 80%, but still, we wanted to be able to get to the 95% that we can get from the saliva. So by adding the saliva to the urine, we were able to increase our detection rate. So blood PCR is not routinely used, is not routinely recommended for diagnostic purposes, simply because, again, with congenital CMV, most of our babies have it early in the trimester, in the first trimester. By the time they're born, they're not having regularly circulating CMV in the blood, because it's now deposited in the sites, whether it is in the brain, in the liver, and then you have spillovers. So when you take the blood, you may miss the period of time, unless, of course, the baby is overwhelmingly septic, has pneumonitis, like that baby that I described, had an extremely high blood level. So the blood level has its role in the very sick babies, the babies who have significant organ dysfunction. Then they may have elevated blood levels, which may help you to watch, to monitor response to treatment. Spinal fluid is not routinely recommended, but if you are doing an LP for another reason in a baby who has CMV, send some for CMV. And then, okay, so brain imaging. So what we have done in Canada is that we would normally, any baby who has congenital CMV would get, symptomatic or asymptomatic, would get a head ultrasound. That's how we started off when we started our population-based screening in 2019. And we would only proceed to an MRI if the ultrasound was normal. However, data changed over time, because, as you know, it's very common to see subependymal cysts in even healthy babies, but that happens also in CMV. And so we started realizing that, and as the literature progressed, even in this study, it basically showed that abnormalities occurring up to 30% of clinically asymptomatic babies. So this study was advocating MRIs in all patients. What we do is apply MRI we used to apply MRI only to the babies who had specific CMV findings, and we would leave out the babies with the tiny subependymal cysts But now we say any baby who has microcephaly, relative microcephaly, any baby who has any changes, any abnormality on the ultrasound moves on. But I believe that we actually may move to this where we don't have a consensus yet that we're doing it in all babies, because it is not necessarily easy in all places in Canada to get an MRI on the babies. So we say all babies with any abnormality in ultrasound, but this study is actually recommending that it be done on all babies, regardless of whether the ultrasound is normal or abnormal. And this imaging highlights the changes that we can see. Obviously, in A, nobody would miss that because there's extensive polymicrogyra in that one. And then, of course, in the middle one, the cyst that you see, we can see that, but the ventricular dilatation as well as the adhesions are also can also be supportive of CMV. All right. So once you have your diagnosis, you need to classify your patients as asymptomatic. I'm getting a lot of feedback. Hello? Am I supposed to stop?
Yes, Dr. Michelle, you can continue.
Oh, there's so much feedback in the background. Maybe somebody needs to be muted. I don't know. Anyway, the classification. So we classify based on what is found, whether there is isolated sensory neural hearing loss or other findings. So this is a Red Book's classification. And the classification helps you to guide you as to who needs treatment. And so the treatment changes were recently made with a new Red Book. And we are still revising. We are now in the revision phase of the next Red Book, which will come out in 2027. However, this is the current recommendation that any baby who has, everybody knows the last box, any baby who has central nervous system involvement should be offered 6 months of valganciclovir. But also babies with single severe organ dysfunction, so let's say only thrombocytopenia but multiple transfusions they would need, or babies who don't necessarily have one single organ but have multiple organs, not necessarily severe but combined together it's impacting, then those babies also may be considered for treatment. But what is new is that we've now agreed that isolated hearing loss, babies who are asymptomatic otherwise and just have isolated hearing loss, those babies should be offered 6 weeks is what we recommend, what the Red Book recommended, 6 weeks of valganciclovir. This is very controversial because the data is still evolving. And in fact, in Canada, many of us as experts still offer those isolated babies with isolated hearing loss 6 months instead of 6 weeks. So we tell the parents 6 weeks is what Red Book recommended based on the limited data that was available, because they really did not follow these babies and they did not do a neck and neck challenge 6 months versus 6 weeks. And so we feel that if the rationale for giving 6 months was to best maximize the baby's brain development over that 6-month period and keep the virus asleep, data is now so in the babies who have isolated hearing loss, there are some people who were not doing MRIs on these babies because the head ultrasound was normal. We now do a head ultrasound, an MRI on these babies, and there's no findings that are suggesting that some of these babies with isolated hearing loss may actually have white matter changes. So if you're in a center that you did an ultrasound, it was normal, the baby subsequently developed isolated hearing loss, and you ended up offering 6 weeks, you would not have dealt with you would not have optimized the baby's care management if there was white matter disease. So yeah, some of us actually offer 6 months, but the recommended red book is 6 weeks, and we tell the parents that and then give them the options. And then obviously if the babies are asymptomatic completely, they don't get any treatment. And then so we all babies who are symptomatic should be referred to an infectious disease specialist for evaluation and follow-up. And then we then apply the treatment as I showed you in the previous slide. And the treatment is valganciclovir that we are going to start. We used to say start within a month, but now with the new recommendations, we have a little bit more time, up to 13 weeks. But even though you have up to 13 weeks, we say the earlier you start, the better the outcome. And so valganciclovir is given for 6 months. IV ganciclovir can be given in the babies who are very sick, and then transition once they can tolerate oral. In terms of the follow-up, these babies need to be seen regularly because of the adverse effects associated with Valgan or ganciclovir. It's known to predominantly, the main one that we see is likely to happen in the first month to 2 months, and that's why we follow them so closely in the first month to 2 months, where we see them weekly. We look for leukopenia, so it can be any cytopenia, but mainly leukopenia, meaning neutropenia, is the most common side effect that we see. You can also get transaminitis. That tends to come on a little later, around about 4 months into treatment. And then you should also monitor the urea and creatinine. In terms of other follow-up, they need, even if they were normal, had normal audiology at birth, they still need regular audiology. And depending on what is feasible in your country, so the Red Book recommends 4, 6, 9, 12. In Canada, we don't do that. We have limited, so we do it Q6 months for the first 2 to 3 years. But in the Red Book, they recommend that frequency that you see in the second bullet, 4, 6, 9, 12, and at 30 months. And then yes, and as well, the baby should be followed for ophthalmology. We have found, so we were doing, in our universal screening cohort, we were doing ophthalmology assessment on all positive babies. And then we just evaluated our 5-year experience, and we noted that we had no abnormalities, eye abnormalities in babies who were asymptomatic. And based on that, we have stopped offering ophthalmology assessment to babies who are asymptomatic and just focus on the babies who are symptomatic. Symptomatic, including if they develop isolated hearing loss, they should get eye exam. So this is controversial, and it will depend on which country. I just gave you our country's spin. Neurodevelopmental evaluations should be done, and these patients should be followed. What is actually and will come out in the next version of the Red Book is the focus now on cerebellar function and vertigo that may occur in otherwise okay babies. And so that aspect is evolving, and you should see more studies coming out on that. So in conclusion, congenital CMV is the most common congenital infection, and it is an important contributor to sensory neural hearing loss. It is an important cause of neurodevelopmental delay in symptomatic babies. New preventive strategies are now being pushed for the pregnant mother, and there is an opportunity to reduce to offer secondary prevention through valacyclovir therapy in first trimester until amniocentesis is done. And babies who have suspicious antenatal concerns or constellation of symptoms should have screening if your country is not already doing universal screening. Universal screening is becoming the way to go if you can establish it, and should be done using a dried blood spot plus saliva if you can afford it. Saliva would be best if on its own if you can afford it, but just recognize that there may be a high false positive rate. Um, and yes, there are new guidelines. MRI head imaging is being done more often, as well as there is an increase in offering of treatment to babies, not just neurologically abnormal, but other system dysfunction or isolated hearing loss. And the length of treatment is still considered controversial for the isolated hearing loss, but for the rest of the babies, it's 6 months. That's it for me. And if you have any questions.
Thank you, Dr. Michelle, for your comprehensive overview about congenital CMV. Any question from the attendees or audience? Okay, thank you, Dr. Michelle. That's it.
You're welcome. Thank you. All right.
Thank you.
Thank you, everyone. Thank you for the moderators and thank you for the speakers. I think now for the first day we've concluded the scientific program, the didactic at least. Now we're moving to the ventilation today. Just to remind you of the workshops that we have in this conference. So the first day we're going to have a ventilation workshop. It's a hands-on workshop. We should be starting shortly. It will be in the Topaz room. It is on the lower floor from here. They will start within 15 minutes. And tomorrow we have a hands-on vascular access workshop, mostly ultrasound guided. We'll be talking about central, peripheral, and midline insertion with hands-on experience as well. So thank you very much for attending, and hope to see you tomorrow, and hope to see the people that registered in the conference, in the workshop, I mean. Thank you very much.